Good morning. Welcome to the 2021 Ascension St. John Stroke and Neuro Critical Care Symposium. Thank you for joining this educational event. This event is intended to provide education that allows all of us to serve our broad community in the most effective ways possible. We are very fortunate to have many gifted and talented medical professionals sharing their knowledge and insights with you today. My name is Mike McBride. I serve as the president of Ascension St. John Medical Center and the chief operating officer for Ascension St. John. Ascension St. John is known for many things within our region. Chief among those is the comprehensive and high-quality stroke and neurocritical care services. What makes this service line so special is the commitment by all those involved to continuous improvement and the adoption of evidence-based practices. You will hear much more about this throughout the day. It is my privilege to open this symposium with a reflection and a prayer. Our tradition in Catholic healthcare is to spend a couple of minutes at the start of meetings and significant events with a reflection and/or a prayer. We do this so that we are ever mindful of the presence of God within us and among us, and to remember that we have been entrusted to do His work through our healing ministry. In the Catholic liturgical calendar, we celebrated the feast of St. Luke the Evangelist on October 18. St. Luke is the patron saint of physicians and surgeons. St. Luke, the inspired author of the third gospel and the Acts of the Apostles, was a native of Antioch in Syria and a physician, and one of the early converts from paganism. He accompanied St. Paul on a considerable part of his missionary journey. He was also his companion while in prison in Rome on 2 different occasions. Luke's gospel is, above all, the gospel of the merciful heart of Jesus. It emphasizes the fact that Christ is the salvation of all men, especially of the repentant sinner and the lowly. His gospel is principally concerned with salvation and mercy. In it are preserved some of the Lord's most moving parables, like those of the lost sheep and the prodigal son. With that quick background, I would like for us to bow our heads while I read the physician's prayer to St. Luke. Most charming and saintly physician, you were animated by the heavenly spirit of love. In faithfully detailing the humanity of Jesus, you also showed his divinity and his genuine compassion for all human beings. Inspire our physicians with your professionalism and with the divine compassion for their patients. Enable them to cure the ills of both body and spirit that afflict so many in our day. Amen. Thank you. Enjoy the day ahead. Now, allow me to introduce Dr. Daryl Thompson. Dr. Thompson is the medical director of our Heyman Stroke Center here at Ascension St. John Medical Center.
Good morning, everyone. It is with great pleasure to welcome all of our virtual guests who are streaming with us for the Ascension St. John Health System's Stroke and Neurocritical Care Symposium. Today is also World Stroke Day. Stroke mortality has decreased in the United States, but remains ranked as the second leading cause of death worldwide. In addition to high mortality, stroke remains a leading cause of serious disability, leaving up to 50% of survivors chronically disabled. In today's symposium, we will identify and define different mechanisms that lead to a stroke and its complications. This will be our guide for our discussions and update on the most effective therapies and interventions. The stroke and neurocritical care sessions will run simultaneously. Our keynote speaker will give his presentation to both sessions at the same time. Both tracks will be available to all registrants in your continuing education and joint accreditation account following the conference. I sincerely hope you will enjoy today's symposium, and your questions are welcome. Thank you for your participation.
Our first speaker is Dr. Wamda Ahmed. Dr. Ahmed completed her medical degree from Stony Brook School of Medicine. Her neurology residency was completed at the Icahn School of Medicine and her neurocritical care fellowship from the Emory School of Medicine. Dr. Ahmed serves in multiple capacities for the Houston Methodist Sugar Land Hospital, including being the current medical director of their comprehensive stroke program. Today, she will be educating us on non-convulsive status epilepticus and continuous EEG monitoring. Thank you, Dr. Ahmed, for taking the time to provide us with this presentation today.
Hello, good morning, everyone. This is Wamda Ahmed. I'm a neurologist, neurocritical care doctor at Houston Methodist Hospital, Sugar Land. Today, I'll be discussing status epilepticus. The objectives will include defining status epilepticus. We'll discuss the epidemiology of status epilepticus, classifications, causes, acute management, indications of and roles for continuous EEG, and long-term prognosis. So the definition of status epilepticus as defined by the International League Against Epilepsy states that status epilepticus is a single epileptic seizure over 30 minutes duration or a series of epileptic seizures which is function not regained between ictal events in a 30-minute period. When in this case, function is generally defined as regaining full neurological function in consciousness and ability to move without weakness or sensory loss. Refractory status epilepticus is an additional level of from status epilepticus in which seizures continue despite treatment with the initial treatments of benzodiazepine and at least one anti-epileptic drug. Status epilepticus is a medical emergency, and so typically management starts much earlier than 30 minutes to be able to abort seizures and improve long-term outcome. Status epilepticus is about 1.3 to 74 cases per 100,000 a year. The incidence is highest in neonates and adults over age of 60. That's mostly because of the underlying causes of status epilepticus are unique to this populations. Neonates may have complications at birth or genetic disorders that make them most susceptible to seizures, epilepsy, status epilepticus, and adults over 60 may have acquired neurological diseases such as strokes or traumatic brain injury that makes them more susceptible to status epilepticus. Overall, 10% of adults who are diagnosed with epilepsy and 20% of children who are diagnosed with epilepsy will experience at least one episode of status epilepticus. Then moving on into classifications of seizures. Before understanding status epilepticus, you have to kind of go back and understand seizures. Seizures can be classified in different ways, one of which is the location of the seizure. Partial seizures are focal seizures that initially start at one area of the brain. They may or may not generalize to both sides of the brain afterwards. Generalized seizures are forms of seizure that start at the same time in both sides of the brain. Always, this form of seizures will accompany loss of consciousness. So this is another way to look at it. So partial seizures, they're focal onset, meaning one area of the brain start to have the seizures and may or may not have loss of consciousness associated with it, depending on the area of the brain that's involved in the seizure development. Generalized seizure would involve both sides of the brain, therefore consciousness is lost. Furthermore, monopartial seizures can further be classified based on the semiology of the seizures. How do seizures look clinically? Simple partial seizures are seizures that involve one area of the brain, and therefore one area of the body is involved in the seizure. And the patients typically remain conscious as the seizure is only localized in one part of the brain. Complex partial seizures are seizures that initially starts in one part of the brain and may affect consciousness to some degree, especially if it generalizes to other side of the brain. Generalized partial seizures, seizures that initially start as focal or partial seizures, one part of the brain, and then furthermore generalized to both sides of the brain, causing altered consciousness. Generalized seizures are seizures that typically start on both sides of the brain. They could be absent seizures, which typically observed in young children, tonic or clonic, depending on how it presents in terms of muscle contractions associated with it. That could typically present as drop attacks. Myoclonic seizures are seizures that are just muscle jerks. And more commonly, we hear about tonic-clonic seizure or grand mal seizures and convulsions, where it typically start with tonic movement, meaning there's a stiffness, followed by myoclonic jerks. This slide here further lists the classifications of seizure we discussed. So generalized convulsive status epilepticus has impaired consciousness. It could be primarily generalized or secondary generalized, meaning it could start at one part of the brain and then involve the entire brain, causing decreased consciousness, or it could start initially in both sides of the brain. Patients may have bilateral tonic stiffening followed by rhythmic jerking. There are much more serious complications associated with it. One, because the level of consciousness is typically depressed, which causes complications potentially in breathing and hemodynamics. And the myoclonic jerking, depending on how long it lasts and how aggressive it is, can cause further problems in terms of rhabdomyolysis. Myoclonic status epilepticus is a type of seizure where it's typically rhythmic or arrhythmic myoclonic jerks. In terms of arrhythmic myoclonic jerks, typically these are consequences of anoxic brain injury, and they can be evoked by moving the patient, turning the patient, or suctioning the patient. Tonic status epilepticus is less common than the last two types of seizure, status epilepticus, and is sustained tonic posture of the body. Focal motor status epilepticus, there are focal lesions, can generalize, and they're sometimes difficult to treat, and patients could develop what's called epilepsia partialis continua, which is status epilepticus involving one part of the body, arm, leg, or face, and sometimes could go on for hours, days, and there are some reports of some types of epilepsia partialis continua going on for years. The next part of the discussion is going to be the causes of status epilepticus. Obviously, that's very important in terms of understanding the underlying cause that triggers status epilepticus to be able to adequately and rapidly treat the patient. These underlying causes are a large spectrum of possibilities. In patients with known epilepsy, alterations in metabolic derangements and changes in renal or hepatic function can trigger status epilepticus. Also, metabolic derangement can on their own in severe cases cause status epilepticus. Acute structural brain injury, such as traumatic brain injury, can result in status epilepticus and subarachnoid hemorrhage as well. Withdrawal symptoms are common causes of seizures and status epilepticus. As we know, with alcohol withdrawal specifically, patients are typically monitored closely for hemodynamics and development of seizures. Barbiturates and benzodiazepine have very similar mechanism in which seizures can be developed very similarly to alcohol. In most of these drugs, patients have high levels of receptors for GABA that are being inhibited chronically with a drug, and when these are withdrawn abruptly, can lead to seizures. Metabolic derangement, glucose hyperglycemia or hypoglycemia can both lead to seizures. More commonly, hyperglycemia does that. Electrolyte dysregulation, especially in calcium, magnesium, and sodium can lead to that. Typically, sodium threshold less than 125 can trigger seizures. Hepatic encephalopathy, in cases where there's a high level of ammonia, especially if there's an abrupt elevation in ammonia, such in cases of acute hepatic failure, can result in variations of neurological complications, including status epilepticus. CNS infections, especially such as encephalitis, which affects the parenchyma of the brain, can lead to seizures and if severe enough status epilepticus. This slide is borrowed from the guidelines for evaluation and management of status epilepticus from the Neuro Care Society, and it has much more detailed discussion of the cause of status epilepticus. I left it here as a reference. In this slide, I think one of the things we haven't discussed in the previous slide is autoimmune encephalitides, such as anti-NMDA receptor antibodies. These are the type of receptors, immune responses we think about in a classically presentation of a young adult female, for example, with history of ovarian cancer or new diagnosis of ovarian cancer. And as part of the syndrome, antibodies are developed against nervous system, developing encephalitis and local inflammation in the brain, causing structural abnormalities that leads to seizures. As we mentioned earlier, there's a percentage of adults and children with epilepsy who develop seizures and status epilepticus in their lifetime. So pre-existing epilepsy is always a high risk patient population for having developing status epilepticus during the lifetime. So now to move on to acute management of status epilepticus, which is obviously a very important part of this talk. This is a general slide just to kind of have a big idea about the things to think about when a patient is presenting with seizures that continue to progress despite treatment, such as Ativan, which is typically, or benzodiazepine that can even be given either sometimes at home or by EMS. Patients arrive to the emergency room and continuing to have evidence of clinical seizures, or they have a depressed level of consciousness concerning for underlying non-convulsive status. So we want to determine first whether the event was a seizure, and many times patients may develop depressed mental status with or without myoclonic movement. In cases such as syncopal episode, convulsive syncope, these patients can initially present with myoclonic movements that then develop, and then they have depressed level of consciousness for a transient period of time. These are not considered seizures, and so a good history is very important to obtain early on to ascertain whether the patient's level of consciousness and presentation is consistent with epilepsy, seizures, or status epilepticus. First thing first, obviously, is to stabilize the patient hemodynamically. Patients with status epilepticus can come in with various changes in their hemodynamics, such as alterations in blood pressure being very high, heart rate's been elevated, sometimes fevers, which can also help determine the underlying cause. And depressed level of consciousness can lead to aspiration and difficulty breathing or retention of CO2. Medical history is also important to obtain. Obviously, as we mentioned, history of alcohol or epilepsy are both underlying causes of development of status epilepticus and help determine the treatment and stabilization of the patient. Thorough physical and neurological exam is important, as focal deficits can point to structural underlying etiology of the seizures. And we want to obtain detailed descriptive information about the seizures from the family, the witnesses, or EMS, if possible, to make sure that these were not tremors or any other types of abnormal movements that are not seizures, and can shift our focus to the actual underlying cause and therefore the treatment. Labs of toxicology are typically done at the same time as the patient being stabilized in the emergency room to look for things that are more likely to be presenting as myoclonic movements or status epilepticus, especially with history of any concern for underlying substance abuse or abnormalities in glucose regulation. So acute management of status epilepticus, like any other medical emergency, the first step is ABC, airway, breathing, and circulation. In patients with status epilepticus, they may stop the myoclonic jerking. They may have no evidence of clinical seizures when they're observed clinically, but they may have significantly depressed mental status, either because of a post-ictal state or ongoing non-convulsive status epilepticus, or it could be also as a result of large doses of benzodiazepine given initially at the initial presentation. And so in these patients, ABG may help if there's any doubt about their breathing and oxygenation. However, Typically, these patients with neurological underlying diseases need a clinical assessment for risk of aspiration and ability to protect their airway, which is most likely to be the indication. They may have a normal ABG, but may still need to be intubated to protect their airway. Also, some of these patients, if they continue to have seizures, such as in case of refractory status epilepticus, may need to get escalating levels of benzodiazepines and sedation. They may inadvertently result in them having further depression in their mental status and ability to protect their airway. I was establishing IV access because the main treatment for seizures will be giving medications that require IV access. Initiate treatment with benzodiazepine if there's any concern that there are seizures. Glucose finger stick is something easy and can be done in the emergency room while patients being assessed on when or seizures first suspected, to ensure that glycemic issues are not the cause, which could be easily treated at the bedside. These patients will require continuous cardiac monitoring because they can have very labile hemodynamics while being taken care of. And thiamine can also be given as a treatment. It's not really for the treatment of seizures per se, but is to protect patients from further encephalopathy and complications if they have an underlying alcoholism and having acute withdrawal. Furthermore, acute management of status epilepticus, we want to normalize CO2 and oxygen level. CO2 specifically can cause myoclonic jerking and abnormal movement and further depression and mental status if the patient is not able to maintain adequate breathing and ventilation. You want to correct any underlying electrolyte abnormalities, as we mentioned, such as glucose abnormalities. And at this point, the patient would start an anti-epileptic bolus, in which we'll discuss the type of epileptics further later in the talk. And if there's any concern for CNS infection based on the history and or presentation with fevers or signs of meningitis or encephalitis from history obtained, then starting IV antibiotics for CNS coverage will be an important, crucial step. Once the patient is hemodynamically stabilized, airway, breathing, and circulations are fully assessed, we move on to diagnostic evaluation to further figure out the underlying cause and treat that seizure's cause as soon as possible. Again, I mentioned here, I underlined while continuing to treat. So diagnostics will come after stabilization, and treatment for any suspicious underlying causes that need to be treated emergently. So the Neurocritical Care Society's guidelines have made a really nice table that I've shared here with you, graphs on timeline to further discuss the importance of doing multiple things simultaneously, doing hemodynamically stabilizing the patients, paying attention to the important crucial steps in management and treatment, at the same time continuing to establish diagnostic tests that are needed, especially based on the patient's history and clinical presentation. So immediately within the first 2 minutes, airway, breathing, circulation are the things that are being monitored and looked for to make sure the patients are hemodynamically stable. And within that period, to furthermore, patients within the first 10 minutes, depending on their clinical presentation and level of alertness, may require oxygenation and ventilation. By the 5 to 15 minutes, patient probably received further benzodiazepine to stabilize them clinically, had some underlying test of underlying history for possible cause of seizure with the associated tests needed for that, including electrolyte, glucose checks, and at this point, further evaluation with detailed neurological exam typically take place in this state. Also, within the same period, between 5 to 60 minutes, patients can have continuous EEG put in if there's any doubt, if they're still having underlying seizure that's ongoing, that's require further medications in cases of non-convulsive status. And within 60 minutes, typically we recommend that imaging modality done, such as a CAT scan of the brain, to evaluate for underlying acute abnormalities, such as subarachnoid hemorrhages or intracranial hemorrhages that can result in seizures. So the acute management of status epilepticus we're discussing today is really focused on hospital treatment of status epilepticus, or different algorithm for EMS and the type of the benzos dispensed and the route of benzodiazepine. But for sake of hospital treatment, we'll focus on IV medications given and with benzodiazepine. So you can see that lorazepam and midazolam are both same level evidence, class 1 level A. Lorazepam is easy to give IV. Usually it's what's typically available in most emergency rooms and bedsides. Initial epileptics, the guidelines are not that very different for most of them. So as you can see, fosphenytoin and phenytoin are more frequently given. There's more familiarity with this drug. It's been used for a longer period of time. And phenobarb, phenobarb typically now is used more for a pediatric population. You see that phenobarb, phenytoin, valproic acid and Keppra have similar level evidence. If fosphenytoin to be used, it's definitely preferred over phenytoin, mostly because of the preservative in which it's administered. Fosphenytoin has less complications with hypotension than phenytoin. And typically most neurologists will recommend valproic acid or Keppra. Keppra has very little side effect comparing to phenytoin and valproic acid, and also are less likely to interfere with other medications and have concern for variability in their level. In this particular graph, this is a bar from also the Neurocritical Care Society. See the doses of initial boluses of benzodiazepine. So benzodiazepine given initially are given as IV pushes to stop seizures. Lorazepam is 0.1 milligram per kilogram IV, can get up to 4 milligram per dose, and repeat every 5 to 10 minutes until clinically there's no evidence of seizures, or if it's being electrographically monitored through the EEGs also. With that comes the risk of hypotension and respiratory depression. This is again emphasizing the role of continuous hemodynamic monitoring for these patients and importance of intubation early on if needed, as continuing these benzodiazepine can further worsen the respiratory status. Midazolam is given less frequently. Midazolam is used when there's no IV access, and it can be given as an IM drug. The side effects are very similar to lorazepam. The diazepam is another. Benzo is given also less frequently than lorazepam, and the complications are similar. So the slide here for you is just a reference to use for the doses given for each. Phenytoin, fosphenytoin, as we discussed earlier, fosphenytoin is typically preferred over phenytoin because it has less complications. These complications are mostly hypotension and arrhythmia. The typical dose is 20 milligram per kilogram IV, and you may give additional doses depending on the patient's size, or especially patients who are known to have been on Dilantin prior to developing status epilepticus. Typically, we'll start with medication they're already on, bolus them to make sure that they're at therapeutic level, check the levels later on to make sure they're not getting to very high levels that could actually, in case of Dilantin, can cause worsening of seizure frequency. A lot of patients with epilepsy present to the hospital because if they have not taken their medications, there's a disruption in their ability to get their prescription, or they were sick, they had nausea and vomiting, and were not able to get their medications, and you'll find that the levels are subtherapeutic. Typically, these levels take a little longer to arrive and before we're really needing to treat acutely based on the clinical presentation. Valproic acid is typically given as boluses of 20 to 40 milligram per kilogram IV. The complications or side effects can include hyperammonemia, pancreatitis, thrombocytopenia, hepatotoxicity. They're not common, but they should be monitored as we continue giving patients beyond the boluses and in maintained level. Keppra is much more preferred nowadays because it does not have as many side effects, and it does not require close monitoring of levels. And it can give in 1 to 3 milligrams IV boluses. So we discussed so far acute management of status epilepticus. I'm going to summarize very quickly. Airway, breathing, and circulation. So hemodynamic stabilizing of the patient, getting initial labs and diagnostic, and eventually EEG and CAT scan the last two should not delay initial treatment with benzodiazepine and at least one anti-epileptic. All of these medications are typically given as IV pushes or IV piggyback boluses. This is before the maintenance level and typically precedes getting any levels back from any anti-epileptics they've had been on before. The next level that could develop is refractory status epilepticus. This is the case in which your patient continuing to have seizures, either clinically or electrographically, or just suspected based on their initial presentation, even before the EEG is back. And that's when they continue to have this status epilepticus, even after receiving the first initial treatment with benzodiazepine and at least one anti-epileptic. Now, for refractory status epilepticus, the treatment is very similar. In this case, you are using more drugs. So if, for example, lorazepam was used initially, you would move to midazolam as a drip, not just boluses, or can start initially with some boluses and see the response and then move into a drip. Propofol, obviously, is only given in patients who are already intubated or need to be intubated prior to initiating propofol. These medications here are given as drip after the patient received multiple boluses of benzodiazepine. In the here you see the list of anti-epileptics. Now, this patient has already received at least one form of anti-epileptic IV bolus, and they're receiving a second anti-epileptic at that time, first as an IV bolus, and then after that continued in maintenance. You'll see that in terms of midazolam, we're talking about pushes here, and this is for the form of midazolam we're giving as IM. But for refractory status epilepticus, the benzodiazepine drips are used, where it's not just the bolus is IV, but you can also do boluses IV clinically based on your judgment to augment the effect of the drips. Typically, the drips are started as a bolus and then as a loading dose and then continued as a maintenance that could be titrated up and down depending on the clinical response using continuous EEG. Ketamine has been more frequently used now in the emergency room for other various reasons, by anesthesia as well, but also in the ward of status epilepticus. I've recently had good responses with ketamine in patients where I already had used midazolam and propofol without success, and addition of ketamine had really improved the response. Most neurologists, neurointensivists would start with midazolam or propofol, depending on the patient's hemodynamic, add one and then the other, and then use ketamine as a third-line agent. With all of these drugs, which one you would start with, how far up you can titrate, is really limited also by patients' underlying physiology, how stable they are in terms of respiratory status and hypotension. Obviously, all of these patients in this particular case, we're assuming are intubated to be able to receive these drips. But the other side effects will be hypotension, which is something more concerning with propofol, for example, than a drug like ketamine. A patient with tachycardia, ketamine may not be the best first-line agent. Okay, so moving on, at this point, we're talking more about diagnostic tools, in this particular case, specifically continuous EEG monitoring and indication for it. Again, a lot of my slides are borrowing from the guidelines of management of status epilepticus from the Neurocritical Care Society, for which you will see the reference for on the bottom of the slide. So according to the Neurocritical Care Society, indications for continuous EEGs really vary. We know that a very high percentage of patients with non-convulsive status, patients who started off with having seizures and then had depressed mental status, are also having underlying non-convulsive seizures that require similar level of aggressive management. So a patient with a recent seizure or status epilepticus with that return to baseline for over 10 minutes, they find, based on the study, 18 to 50% of them are having ongoing non-convulsive status epilepticus that was only diagnosed with a continuous EEG. Continuous EEGs are commonly used now in post-cardiac arrest patients, some of which have myoclonic arrhythmias, arrhythmic myoclonus from anoxia, and some of them are epileptic and some of them are non-epileptic. Some of these patients remain in a comatose state and in a good percentage of these patients, they can have underlying status epilepticus that can be treated. Still controversial whether treating and looking for these underlying non-convulsive seizures in this particular population really improves or changes outcome. But if there's any suspicion that patient's mental status is affected by underlying seizures, treatment typically is warranted. Epileptiform activities or periodic discharges in the initial 30-minute EEG. These are for patients who may not be as clinically evident having status epilepticus, having waxing and waning mental status. You get an EEG, and the initial 30-minute EEG shows some epileptiforms, which tells you that they are high risk of having frequent seizures and status epilepticus. Typically, these patients would leave on a continuous EEG for 24 or 48 hours, and they're found in studies that a good portion of these patients are found to have multiple seizures occurring over that period of time, and treating those seizures can improve their outcome. And finally, in patients who are suspected with non-convulsive seizures because of depressed mental status, these are patients who may not present initially with seizures, not straightforward as typical status epilepticus patients we're talking about. These are patients who typically are in the MICU. They have medical abnormalities, septic shock, for example, and found that putting continuous EEGs in these patients, we uncover seizures that are ongoing. Treating these seizures can improve their outcome. Finally, prognosis. So the prognosis with status epilepticus is similar to prognosis with any other disease. It's really the underlying cause of status epilepticus that really determines a large portion of how well those patients will do long term. So it varies based on the underlying cause. So, but also some specific variables that will make sense to you as we go over them increases the risk of long-term poor prognosis. And this is mostly not because of the status epilepticus itself, but this particular patient population has underlying comorbidities that makes it more difficult for them to recover from critical illness in general. So older patients with a lot of comorbidities, patients with high Apache 2 score when they enter the hospital ICU, these tend to, for obvious reason, have poorer long-term outcome in general. Patients with new onset status epilepticus have actually 6 times the increased risk of mortality from status epilepticus than patients with epilepsy. And that makes sense because if a patient has epilepsy, this is a long-term disorder. They have seizures throughout their life from an underlying either genetic dysfunction or a scar that's known in the brain from some other underlying neurological disease. The patients who have their first epileptic event present as a status epilepticus, it tends to point to the fact that these patients are having new onsets, significant structural brain abnormalities that are resulting in them immediately going into status epilepticus as their first presentation of seizures. So this underlying pathophysiology of this new onset seizure developed starting as status epilepticus is the underlying cause of why they have significantly much more increased risk of mortality. Convulsive status epilepticus after anoxia is also a sign that the brain has severe anoxic brain injury. They also have higher level of mortality. So to recap, we discussed status epilepticus definition. So the definition is the numbers you need to remember is 30 minutes. So 30 minutes of one seizure going for the whole time or multiple seizures, and the patient's up to 30 minutes still not regain full level of consciousness and neurological function. Obviously, we would treat way before we get to the point of 30 minutes in most places. The underlying cause of status epidemiology of status epilepticus is statistically is not extremely common. You're going to go see, it's most likely to see it in places with neuro care, ICUs, or high trauma levels hospitals. Well, you get to see more of status epilepticus. The classification of seizures is discuss generalized seizures that start from both sides of the brain, having seizures, which is results in depressed mental status, or one part of the brain, such as in focal seizures, that can stay focal. So one part of the brain in which consciousness is not impaired or can generalize to both sides of the brain. It's called secondary generalized and causes depression and mental status. The cause of status epilepticus are very wide, differential for, and that anything physiologically that can alter the brain function can cause status epilepticus. But in addition to that, patients with epilepsy have can develop status epilepticus if they've missed their medication or they have some other underlying new metabolic abnormality that can lower their seizure threshold. Finally, electrolyte abnormalities such as sodium. The key level to think about is sodium below 125 is what typically is below the seizure threshold. This also varies obviously from individual to individual. And one thing to mention, obviously alcohol withdrawal, benzo withdrawals, and pentobarbital withdrawals can lead to status epilepticus. The acute management of status epilepticus is such as any medical emergency, airway, breathing, and circulation, then urgent treatment with benzodiazepine, initially as IV boluses, typically with lorazepam, and at least one anti-epileptic. And if the patient is suspected to continue to have seizures, whether it's convulsive or non-convulsive, then it's followed by typically another anti-epileptic plus or minus a sedative as a drip, and these patients are typically intubated. Continuous EEG monitoring plays an important role, as many patients who initially presented with convulsive seizures may develop non-convulsive status, in which an EEG can help us figure how aggressive to titrate treatment going forward. EEG also plays an important role in patients who may not initially present with clinical convulsions, but have depressed mental status, and an EEG and continuous EEG can uncover underlying seizures that could be treated. Finally, the long-term prognosis, as we mentioned, is really dependent on the cause of the seizure itself. So structural brain abnormalities, large abnormalities in the brain are more likely to cause long-term poor prognosis, such as an anoxic brain injury. And with that, I conclude my talk. I hope you found it helpful, and please feel free to use the slides for references for some of the dosing and complications. Have a good day.
Our next speaker is Dr. Yasmin O'Keefe. Dr. O'Keefe completed her medical degree in 2011 from St. James School of Medicine in the Netherlands. She completed her neurology residency in 2015 from the Department of Neurology at the University of Illinois College of Medicine, where she was chief resident. She then went on to Duke University, where she completed her neurocritical care fellowship in 2017. Dr. O'Keefe currently serves as the neurocritical care attending for the Ascension St. John Neurocritical Care Program. Today, she will be educating us on brain death determination. Thank you, Dr. O'Keefe, for taking the time to provide us with this presentation today.
Thank you, Taylor, for your kind introduction. Hello, everyone. Today I'm here to talk about brain death determination and the pitfalls and challenges that we face while doing so. My name is Yasmin Ali O'Keefe. I'm an intensivist, a neurointensivist, and a neurohospitalist with Ascension St. John Medical Center. I have no disclosures pertinent to this conversation or presentation. Just before we start, I'd like to go over the presentation objectives that we hope to learn over the next hour. I'd like to describe the history of brain death declaration and the concept of brain death as it was incepted. I'd like to define and outline the criteria for brain death determination. I'd like to discuss how to declare brain death and/or situations in which ancillary testing is necessary or needed. I'd like to discuss the legal and logistic challenges of brain death declaration around the country and around the world. To begin, let's talk a little bit about the history of brain death and background of the inception of the concept. So the definition of brain death is a unitary phenomenon, regardless of causation, resulting from either irreversible failure of brain or circulatory function. That is the legal definition of death. Brain death is also known as death by neurological criteria, a term I'll be using interchangeably with brain death. There's a long history of the development of the concept of brain death, and it can be difficult for some people to understand, seemingly because there's ongoing cardiac function and respiratory function, and sometimes even pathological spinal reflexes, which makes the clinical picture very confusing for grieving families. It's complex, and it's an issue wrought with innumerable confounders, which is why we need people and trained physicians to help determine brain death. Very simply, when evaluation of a patient is going on for brain death, you should ask yourself 3 basic questions. 1, is this exam consistent with death and brain death? 2, is apnea testing indicated at this point? And 3, does this patient need an ancillary test? To go back even further, talking about the history of brain death from its inception, we have to go back a little further to understand just how we got to this point. So from this chart, you can see that there are several salient issues or points in time in which we have gotten to this issue. So in 1947, the first successful cardiac defibrillation was performed, which actually set us far ahead in medical resuscitation. Additionally, around the 1950s, 56, Zoll itself developed an external defibrillator, which only furthered our ability to resuscitate critically ill and dead patients. Around the mid to late 50s, we became more aware of the spectrum of neurological injury in the setting of cardiac arrest, and several different practitioners started to discover and describe comatose states. 1959 was a big year for us. In 1966, the first CPR resuscitation guidelines were developed. With all of this information and more, we decided that it would be prudent to actually define neurological death because of our ability to resuscitate people but not get them back neurologically, or standing neurological function was being noticed more and more. So in 1968, the concept of brain death was incepted. It's important to recognize brain death as a legal form of death at this point. It can be variable and complex because of social issues, cultural impact, religious issues, and this can actually both apply to both patients and providers alike who might have distress at this concept. Unified Death and Dying Act in 1981 stated, because there was note that there was ethical problems created by the advancement of modern medicine and ventilatory support, stated that a uniform definition of death was determined by applicable medical standards. And because of unitary phenomenon, regardless of causation resulting from either irreversible failure of brain or circulatory function had been noted in past cases, they both declared both cardiac and brain death as legal forms of death at this year. Thus, from this point on, brain death is equivalent to clinical death. The challenge of this will be discussed later. Before we dive into brain death and determination, it's important to discuss the nature of irreversible brain injuries which lead us to clinical diagnosis of brain death regardless. So, very simply, cerebral injury leading to cerebral edema is usually the cause. It comes in many forms: stroke, ischemic or hemorrhagic, subdural hematomas, epidural hemorrhages or hematomas, traumatic brain injuries, global anoxic injuries, and many more. The very basic fact is that all of these types of injuries or cerebral injuries can lead to increased intracranial pressure from space-occupying lesions, which then leads to physical compression and herniation of the brainstem, which results in brain death. In order to further understand this, it's important to discuss the concept of the Monroe-Kelly doctrine, which is very simple. It states that there are three intracranial components: brain, which makes up about 80% or the majority of the intracranial contents, blood, which is about 10% of the intravascular space, and then CSF, which is the other 10%. Obviously, the skull is a very hard fixed structure, and only a finite amount of volume is allowed within it. Thus, if one of the contents goes up, another has to go down. It's a closed system, and we have to compensate for that, and that can only happen to a certain point from a volume standpoint. The skull can accommodate around 150 cc's of extra volume, and past that, it's not feasible, and herniation patterns can manifest. Herniation patterns, as we've learned, can come in many forms, and they are a symptom of excessive intracranial contents or increased intracranial pressure. Very simply, it has to be decompressed from the path of least resistance. You have to ask yourself which Monroe-Kelly doctrine component is applied here. Is it too much brain matter, too much spinal fluid, or too much blood? And the answer can be one or all of those things depending on the patient. This is a neurological emergency, as it can result in death or neurological death. There are different types of herniation patterns that we hear described, including uncal herniation, subfalcine herniation, transtentorial herniation, transcalvarial herniation in neurosurgical patients particularly, or tonsillar and brainstem herniation, which is terminal brainstem herniation, which leads to the final diagnosis of brain death. All of these beget the other, and all of them are very dangerous when they occur. Next, we move on to brain death declaration procedure. The process of declaring brain death is complex and multifold. First, we must have a clinical exam, imaging, and a mechanism of injury leading to the irreversible herniation of brain tissues identified. If those are identified, you must exclude all contributory conditions or medications leading to that clinical state potentially. If that has been done, ensuring all criteria are met for brain death and apnea testing must be ensured. Apnea testing can then be undertaken, and if it is inconclusive or unable to be completed, you must proceed to an ancillary test. And if conclusive, cessation of ventilatory support should be undertaken. Before we dive into this, it's important to examine who should be performing apnea testing. Obviously, neuroscience from neurology and neurosurgery are well-versed in neurological exam and clinical brain death, so these seem like reasonable parties. But because of our lack of availability or lack of appearance in many hospitals due to just access issues, sometimes this isn't feasible. So other colleagues who are highly trained, such as neuroanesthesia, trauma, or ICU, also seem like reasonable parties to declare this, as this is a common potential condition that may manifest in each of these ICUs. There's a lot of discussion regarding attending versus trainees declaration. As a teacher myself, I firmly believe that trainees should experience and see all of these neurological conditions. However, the declaration should be undertaken in a very supervised and closely monitored environment. So often I'll let trainees do a first exam, and then I do my own separate exam to confirm their findings. The World Brain Death Project was a paper that recently came out, which is a landmark study and trial of different criteria for brain death declaration and standards that should be upheld nationally and even internationally. And they come up with some very good ideas about who should perform apnea testing and brain death evaluations. They believe that practitioners who have completed training and are licensed to independently practice medicine, so attending physicians, should be considered. There should be periodical certifications, which is reasonable, especially if neurological examination is not something you do every day. And trainee education or other disciplines should also be regularly recertified, which is very reasonable as well. Next, when deciding brain death declaration, these patients must meet certain prerequisites, including, and importantly, you must be able to answer yes to all of the following questions before you can proceed with apnea testing or brain death declaration. 5 half-lives at minimum must pass from all contributory medications, including opiates, barbiturates, sedatives, and paralytics. In the AAN parameters, which is essentially the gold standard of brain death declaration at this time, they do mention that absence of metabolic derangements should be there in order to be able to move on with apnea testing and declare a patient brain dead. This is largely true, and all derangements should be corrected as able. However, there are certain situations in which that is kind of challenging or impossible, and actually might be a result of the actual brain death event or the herniation event. A good example of this is hypernatremia from diabetes insipidus, which infers that the pituitary has been destroyed from the increased ICP and the global injury. So often we actually do see hypernatremia and diabetes insipidus in brain death cases. Another salient point, an old ER saying is you're not dead until you're warm and dead. And this is actually a very valid point when it comes to brain death declarations, as we must make sure that these patients are euthermic before we proceed to declaration, because severe hypothermia or even mild hypothermia can mimic brain death and lack of brainstem function until they're rewarmed. This is a prerequisite checklist that I use for all patients who I'm declaring brain death, and it's an excellent checklist that helps make sure that all of these criteria are satisfied prior to proceeding. So they must be in a coma, their neuroimaging must explain the coma, CNS depressant drugs should be absent, particularly barbiturates, no evidence of residual paralytics, and sometimes we use train of 4 to prove that, absence of severe acid-base electrolyte endocrine abnormalities like we talked about prior, normothermia, systolic blood pressure greater than 100, i.e. a perfusing blood pressure, and no spontaneous respirations. On the clinical examination, there are certain techniques we use. We must test all brainstem function prior to proceeding with apnea testing. Different techniques we can use. For the pupillary reflex, we often use a swinging flashlight test, as the name would infer, means swinging the flashlight from one pupil to the other. Both pupils should be fixed and dilated, non-reactive. Another way to objectively prove this is a piece of technology called a pupillometer, which very objectively measures pupillary reaction and pupillary size. The NPI, or neurological pupil index, should be 0 bilaterally. A corneal reflex, in which we rub a sterile cotton swab over the cornea to ensure that there's no blink or corneal reflex present. Oculocephalic reflex, or oculovestibular reflex, i.e. cold calorics, should be performed. Please take caution in C-spine immobility and C-spine injury, as you should not be manipulating the head side to side if that's the case. And take caution in oculovestibular reflex to make sure that tympanic membranes are intact. If there's a ruptured tympanic membrane, that prohibits this. Cough reflex, so you should deep tracheosuction all the way down to the carina. The gag reflex with deep swab or suction to the posterior oropharynx, and I do that bilaterally with a Yankar. Spinal responses are admissible. For example, the Babinski or triple flexor or the Lazarus reflex, both of which are central nervous system exempt reflexes and go through spinal pathways. If the patient has the presence of any of those brainstem reflexes outside of the spinal reflexes, they are not brain dead, and apnea testing cannot proceed after this point. Apnea testing must be appropriate for testing, of course, is one of the preliminary prerequisites for a patient. They should be hemodynamically stable with a perfusing blood pressure and normothermic, at least 36 degrees or greater. The ventilator is then adjusted to provide normocarbia with a PaCO2 of between 35 to 45 millimeters of mercury and order a baseline blood gas. After that, the patient is pre-oxygenated with 100% FiO2 for at least 10 minutes prior to the testing and should have a PaO2 of over 200 so that we ensure that hypoxia is not the reason for their examination. In addition to, that could lead to hemodynamic instability and a code, potentially. At this point, we disconnect the ventilator and put 100% FiO2, or at least 6 liters of FiO2 nasal down the endotracheal tube to the carina to ensure adequate oxygenation throughout the whole test. Throughout this entire test, there should be absence of spontaneous respirations. What we're essentially allowing at this point is a very strong chemostimulus, i.e. rising CO2 due to lack of ventilation, to trigger the brainstem. A working brainstem will trigger a breath in order to ventilate and remove the CO2. However, a patient with an absent brainstem response or brain death, will not be able to do this because the brainstem is irrevocably damaged and cannot initiate a breath. After about 8 to 10 minutes, we'll draw an arterial blood gas and the patient will be reconnected to the ventilator. At this point, if we see either a rise of PaCO2 of greater than 60 millimeters or greater than 20 from their baseline, this is considered a conclusive apnea test. This is important to note in chronically hypercarbic patients that you must see a greater than 20 millimeter of mercury rise in the CO2 rather than a greater than 60 because often they run around that range to begin with. The apnea test is over if one of three things happen. 1, the patient does not breathe. If there is an appropriate rise in the CO2 like we discussed prior, the test is admissible and death is declared at the time of the ABG that was last performed, and that is considered their legal time of death. The two other situations are that if the patient becomes unstable, the test must be aborted and the test is not considered admissible and brain death cannot be declared by apnea test. Thirdly, if the patient takes a breath, the patient is not brain dead because they have brainstem function in some form and the test is not considered admissible and they are not declared brain dead. They are likely very grievously injured from a central nervous system aspect, but they are not considered brain dead. There are several situations in which apnea testing has really become very pertinent. In cases, as we get better at resuscitating people and keeping people alive, like ECMO, or external corporeal membrane oxygenation. For venous-venous ECMO, over time we've come to understand that apnea testing can be performed and can be conclusive if the following are performed. The sweep is decreased to 0.5 to 1 liter per minute. The ABG should definitely be collected from the post-oxygenator ECMO circuit and the distal A line to ensure that the patient is oxygenated but not ventilated. 100% O2 should be maintained, just like in a standard apnea test. And we should, as with a standard apnea test, be watching for spontaneous breaths. The test targets an ABG of less than 7.3 and a PCO2 of greater than 60, which is similar but not quite the same as a standard apnea test, but with the same concept that a working brainstem should trigger a breath or a breathing response, and if it doesn't, then this can be considered an admissible apnea test. In VA ECMO, because of the mechanics of the circuit, there's no standard at present, and we cannot declare patients brain dead via apnea test in this patient population. Brain death in pregnancy. So for obvious reasons, this is a very challenging and distressing situation for both family and provider team. Multidisciplinary team approach and support is necessary and imperative. The monitoring of the fetus should be undergone with medications selected based on fetal safety side profiles. At this point, we often allow for preparations for C-section between 26 to 33 weeks, i.e. lung maturity, to allow for the viable fetus to be born. And until that point, we'll sustain the mother in her current state. And oftentimes, if they're really far from being viable, tracheostomy is indicated and or present. And these issues were discussed in the World Brain Death Project paper of 2020 and are a very interesting read if you're interested more in reading about this. It's also prudent to be aware of brain death mimics, and these things should be excluded prior to even testing so that we don't falsely declare someone brain dead, including hypothermia, hypotension, drug intoxications, either illicit or blood alcohol levels that are very, very elevated, or iatrogenic, like barbiturates, opiates, sedation. Severe Guillain-Barré syndrome, and this is certainly a case I've actually seen from a severe case of GBS that led to complete brainstem demyelination, but that patient was actually awake on the inside. So EEG was very helpful there. And the one clue that we had with this patient was that he didn't have imaging that explained his coma. His head CT was normal, so we could not proceed. Paralytic medications, so residual paralytics, particularly in renal failure where they have not been adequately cleared, or in rare cases of undiagnosed myasthenics who are inadvertently paralyzed persistently due to depolarizing or more depolarizing paralytics. So train of 4 is very useful in these patients to make sure that they are not persistently paralyzed. And locked-in syndrome, if bad enough, sometimes people can look like they're in pseudocoma. Often they still have retained eye movements, but it takes very careful, close examination. And once again, their imaging may not explain. There might not be a global cerebral injury that explains why they're in their coma. So these things should be considered. Lastly, high cervical spinal cord injury, which can lead to loss of lower cranial nerve functions, particularly apnea and swallowing reflexes, but they tend to be in various forms of awake or stuporous sometimes, depending on their degree of head injury. So, in cases that we cannot declare brain death via apnea testing, ancillary testing must be pursued in cases of suspected brain death. Occasionally, due to vital sign instability, clinical exam prohibits, for example, we're unable to examine their eyes or their pupils due to injuries, or they have bilateral tympanic membrane ruptures and we can't do oculocephalic or vestibular reflexes, and we can't clinically examine them. An incomplete exam is then not admissible, or they become unstable during testing. Ancillary testing can serve as a surrogate if apnea testing cannot be performed or completed. Once again, I just want to reiterate that ancillary testing is not necessary if there's a conducive or conclusive apnea test performed prior. So, digital subtraction angiography, or DSA, is the gold standard for ancillary testing for brain death. What it shows is a lack of intracranial flow, i.e. no brain perfusion, and often we only see external carotid perfusion, which cannot supply the brain in entirety. Unfortunately, it's an impractical test due to the cost, it's very labor intensive, and the availability is spotty depending on the facility you're at. In addition, that you need an experienced practitioner or provider to perform it. So it's not a very practical test at times, but it certainly is a very vivid one. So that image on the right shows lack of intracranial flow, and on the left shows extracranial carotid flow, which is not intracranial at all. So essentially, the entire brain is not being perfused due to severely high ICP, not allowing the cerebral perfusion pressure to perfuse. Nuclear med scan is far more productive. It's essentially an absence of radioisotope uptake from metabolically active tissues, and what's more metabolically active than the brain? Often we see the hot nose sign, which is shown with this first arrow, which, as the name suggests, shows uptake of that radioisotope into the nasal plexus, which is very vascularized and very highly metabolic, but an absence of intracranial uptake, which is the light bulb sign, which essentially, as the name would suggest, looks like an empty light bulb, where that emptiness should be dark, hypermetabolic tissue of the brain, but there isn't, which suggests that the brain is completely devoid of any flow and metabolic activity. Practically, you must consider that this patient should be hemodynamically stable for this test, and tube feeds should be held prior to initiating this test, just given the practicalities. Transcranial Doppler, CTA, or MRA angiography. Transcranial Doppler is a practical way to confirm brain death, or an ancillary test to confirm brain death suspicions. Often what we'll see is biphasic oscillating flow and systolic spikes or reversals of flow and diastole, which is seen in the the fourth pictorial representation. The reason why TCD is sometimes challenging is that you must have a prior study with presence of flow proven to prove that the windows are acceptable, which is often not the case when these patients come in. We don't have a reason to have a prior TCD on file unless they've been in our system before. And in this case, at the World Brain Death Project's suggestions, 2 studies, 30 minutes apart, confirming the biphasic oscillating flow and diastolic reversal should be performed and demonstrated. So it's a great test, but it's sometimes technically challenging to prove. When it comes to CT angiography or MR angiography, I'll caution this, that they are not recommended because they're just not proven at this point to be sensitive enough for ancillary testing. And if you have to use one, CTA should be prioritized if it's the only choice, but I will suggest that this not be used at this time. Electroencephalogram, or EEG, can be helpful in many other ways, but is wrought with confounders in brain death testing. What you should see in this pictorial representation is electrographic silence or flatness throughout all the leads, which shows lack of electrical activity throughout the brain. This is a weak level of evidence for use for brain death ancillary testing because of the following reasons. It's wrought with technical confounders. There must be a specific lead placement protocol, so you must have an experienced technician. The ICU in which these are being performed are electrically noisy environments, thus you can have impedance and interference from other electrical sources. And it's subject to much potential error, thus it's not seen as a sensitive enough test. And it should be used, if it is used, in conjunction with SSEPs and clinical exam, or in cases where you cannot use any other ancillary testing. So I will caution the use of EEG for ancillary testing for brain death declaration. Next, we should move on to contemporary issues in brain death determination. So, interestingly, around the country, it's an important thing to realize that while we want families to be on board with all of the things that we're doing in the hospital, that determination of death by the UDDA, the Universal Death and Dying Act, in Virginia, determination of death is a clinical decision that does not require the consent of the person's representative. And logistically, when you think about it, to declare death, it's a factual event. We don't need permission. If anything, it's necessary to declare death so that that patient may rest. But this varies across states, even in our own country, on opinions on this. For example, in Montana and Kansas, the courts say yes to permission being needed from families to proceed with pediatric brain death declaration cases. In Virginia, clinicians, on the other hand, can administer apnea testing over family objections. These are very stark contrasts in practice. When it comes to cessation of ventilatory support, and I say that very purposely, not withdrawal of ventilatory support, it is immoral and illegal to continue care of a dead body. Thus, we must remove ventilatory support within a reasonable amount of time. Illinois, California, and New York go as far as to actually lay out a reasonable amount of time of 24 to 28 hours as a reasonable accommodation to families to allow them to gather or travel to get in. But past those times, they are actually within their rights to then remove or cease ventilatory support of these patients. There are certainly religious-based exemptions, for example, in New Jersey. So if we already have so much discrepancy around our country, around the world it varies even more. There's certainly heterogeneous practice patterns, and those are multifactorial, but certainly due to religious cultural implications, one, and two, infrastructure and capabilities of these different facilities. Certainly there's a standard and uniformity that is necessary. There was an interesting study by Walster and his colleagues that showed that around the world, only 66% of determinations were by an attending, which means the remainder were done by trainees likely, and that might just be a factor of availability or expertise, or both. Certainly around the world, we see more heterogeneity and even physicians who are opposed based on their own religious or cultural grounds against brain death declarations, and that's a reasonable point to be made. And if that is the case, those physicians may seek transfer to another qualified physician if they cannot morally declare someone brain dead based on their own beliefs. So certainly the need for improving uniformity is there, not only in our own country, but around the world, it seems. When it comes to improving uniformity around our own country, Wang well demonstrated this in 2017, that out of the 51 institutions that he reviewed, most of them very highly functioning academic centers, that 25% of them likely hadn't updated their brain death protocol or algorithm in at least 5 years or more. And the majority had greater detail, but there certainly was a need from all of those institutions reviewed for a more stringent protocol reflecting national standards, certainly, because it shouldn't matter what state or what county you neurologically die and you should still be declared dead one way or another in a different place. There's no true complete uniformity across even the top institutions in this country, which is why this is such a salient and pertinent issue and something we should continue to talk about. And regular review of institutional policies compared to national standards should be a priority to reflect the national standard, if not more consistently. When it comes to religion and brain death declaration, certainly there must be respect for other views, cultures, and religion, and a very, very cautious, if not very sensitive hand should be taken with this, especially if there's major objection. Of course, multidisciplinary support teams are very helpful in the way of pastoral support, social work, ethics, for not only the family, but sometimes the teams involved as well. We should make a reasonable effort to notify the next of kin that the testing will be ongoing. However, consent is largely not mandatory, except in PEDS cases in some states. And somatic support, ventilatory support, pressors, etc., should be allowed for a reasonable amount of time, generally 48 hours or less, to allow for family members who want to visit prior to cessation of ventilatory support and care. If there is objection, we should try to recap the interventions and attempts to prevent should be made. Attempt to explain the situation globally and explain the brain injury and the irreversible nature. And if they're still maintaining objection and they're still unwilling to proceed, families should be allowed a finite amount of time, a reasonable amount of time, to arrange for transfer to an accepting facility, which, as you can imagine, can be very challenging and difficult for them. But certainly we want to make sure that everyone feels heard and respected. It's suggested that support should be discontinued if the hospital bed is required for another living patient and no other bed is available, and that should be handled very delicately as well, but it is true as the patient is deceased. I thought this a very interesting chart of most of the major religions and their views on brain death, and largely brain death is accepted as an admissible form of death or is not definitively discussed in their scriptures. There are few religions that do not recognize it as a form of legal death. Only cardiac death is recognized. But I thought it was important to educate ourselves on just how different some of the beliefs may be and how we should be respectful of that, but definitive in our diagnoses regardless. When communicating about brain death, once again, it's important to reiterate that brain death declaration is not a choice, it's a necessity, just as cardiac declaration is as well. Permission is not necessary. We should set expectations from the beginning of the declaration onwards to allow patients and their families to grieve appropriately and anticipate what's coming next. I feel that most of the fear and the upset comes from just the uncertainty of it. Avoid ambiguous statements or euphemisms, such as passing on or transitioning. Avoid vague language, which in a grief state can be very confusing and can be misinterpreted. And remember, as there is no life to withdraw, there's no life there is no withdrawal of life support. Once again, very cautiously saying cessation of ventilatory support is something I very purposely say. And instead, use clear, concrete terms consistently and avoid jargon, such as death by neurological criteria. Brain tissue is permanently dead. This is a very serious situation. Seek teachback and confirm understanding, as this is very, very difficult in large amounts for the layperson to take in and digest, and takes time. Of course, compassionate listening is key, and answer any questions as you're able. Often we'll get asked, why does this have to happen so quickly after the event when it comes to ventilatory support? And what I often explain is just as someone's heart stops working, we are seeking to determine death and let that patient rest with dignity and peace. If they express religious or cultural objection to brain death and say, I don't believe in brain death, we should obviously have respect for that and make sure that they feel heard. Attempt to seek a middle ground or understanding or make arrangements if we cannot come to a concession. The last topic I'll talk about is organ donation. Personally, I'm a very strong proponent of organ donation. However, I have strong feelings about brain death and organ donation. As physicians and providers, we are here to preserve life, and organ donation occurs after death. Talking about donation as a care team can be confusing to families because it seems like a conflict of interest, actually. There are blurred lines of roles, and it's a very vulnerable and difficult emotional time. Thus, organ procurement agencies exist for this reason, and I prefer to keep the roles and lines clean and let them handle all donation conversations. I do not broach donation topics at all, and if I'm asked about it, I say, we have organ donation procurement agencies. Let me get you in contact with them so that all of your questions may be answered. From the technical recommendation aspect, some agencies will come in and bring their own physicians and providers and take ownership of the patient from there on, and sometimes they remain in our ICUs with the organ donation agency requesting orders from us. From technical aspects, we want to keep the status quo. So you want to maintain normal labs as able, particularly your potassium, your blood glucose, and your hemoglobin. If you see tachyarrhythmia, consider amiodarone. If you see bradyarrhythmia, you should take caution with atropine because there's actually no vagal tone left due to the death of the nucleus. And chronotropic or inotropic medications or transcutaneous pacing should be considered. Crystalloid and colloids are okay. We don't use it all that much, but hex starch has been shown to be deleterious and should be avoided. We should maintain normothermia. And vasopressin and IV fluid replacement in DI, which is common after brain death, should be undertaken. Thyroid hormone replacement and steroids are admissible and actually do help maintain hemodynamic stability as well. Thus, in summary, brain death or death by neurological criteria is a complex process wrought with many challenges. Brain death is equivalent to clinical or cardiac death. Knowledge of the criteria and clinical assessments are crucial in providing this diagnosis. Standardization of protocols are necessary to uphold the highest medical and ethical standards and should be pursued not only across the country, but across the world. And knowledge sharing competencies and regular review protocols are imperative to growth to help this patient population and their families. Lastly, a compassionate but definitive approach is crucial when declaring brain death and helping these families cope. These are my references for review. Thank you so much for having me speak today. It's been a pleasure.
Thank you, Dr. O'Keefe, for that presentation. We really appreciate your time and your effort putting that together for us today. We do have a few questions from the viewing audience, if you have a moment to answer those.
Yes.
What is the most important thing you would like other providers to take away from your presentation today?
That's a great question. I think the biggest thing that I can really put out there is, even after 10 years of doing this, the biggest piece of advice I give is use the checklist. Every single time, do it the same way, and you can never miss a step because you have to be really sure about this diagnosis. It's a life or death diagnosis, and you want to be absolutely sure that it fulfills all the criteria. The AN has a great template and checklist for brain death declarations, and I use that every single time.
Great. Awesome. That's a great resource for everybody. The next question is, what is the most common misconception surrounding brain death determination?
I think that's a great question too. One I come across a lot from different providers is the misconception that a patient can't be declared brain dead when they're on vasopressors. It's an interesting misconception, and the physiology is actually really interesting because any, if not all, of these patients will actually be on pressors, given the fact that their medulla has been destroyed and blood pressure control comes from there. So if anything, I think that pressor requirement is actually a strong sign that this is actually a true diagnosis.
Sure.
I think also, back to my first point, is that oftentimes people think that this is a one shot and that's it type of diagnosis, and many times I've had to reset and retest each day. any myriad of things could happen. So the patient could be nearly herniated, and then when you do an apnea test, can take a breath sometimes, and then when you test again, has completed their herniation. So that happens infrequently, but every once in a while.
Yes.
Or the environment just isn't right. For example, you can't get your ABG absolutely correct. You can't get their hemodynamics perfect. If that happens, you just reset, redo everything, and then go on with your confirmation. But you want to make sure that the environment is absolutely correct and perfect for declaration before you proceed. And to that point, again, using a checklist is actually very helpful because it'll help make sure you don't miss a single criteria. So
Yeah, absolutely. You want to be 100% sure. So in order to do that, you want to make sure that you have your checklist and all of your things in order, all your I's dotted and your T's crossed.
absolutely.
Okay, well, thank you so much for joining us today.
Thank you.
And up next, we'll have our next presenter.
I grew up loving the balance beam, but I don't know that there is ever going to be a perfect balance in life. Being a mom is a constant juggling act. Caring for yourself is where it starts. It's the foundation. It's not a selfish thing to take care of your health. It is very selfless. If we don't take care of our health, we can't be here for all of those that depend on us. You have an endless to-do list, but make sure your health is at the top of that list.
Start a conversation with a doctor who listens at Ascension St. John.
Our next speaker is Dr. Leslie Kempler. Dr. Kempler received her Doctor of Osteopathic Medicine at Kansas City University of Medicine and Biosciences in Missouri. She then completed residency training in neurology at the University of Kansas School of Medicine, where she was chief resident. She completed a fellowship in neurocritical care in the Vivian L. Smith Department of Neurosurgery at UT Health. Dr. Kempler currently serves as a neurocritical care attending for the Ascension St. John Neurocritical Care Program. Today, in conjunction with pharmacist Robert Holliday, she will be educating us on acute cerebral hemorrhage management and coagulopathy reversal. Thank you, Dr. Kempler, for taking the time to provide this presentation.
Thank you for the introduction. I am Leslie Kempler. I'm a neurointensivist with Ascension St. John Medical Center. I'm here today to talk about intracerebral hemorrhage. These are my disclosures, for which I have none. So to kick things off, we'll first discuss ICH risk factors. Among the major risk factors for intracerebral hemorrhage, hypertension is the most important. It has a stronger association to deep hemorrhages, such as in the basal ganglia and other deep white matter structures, than it does to more cortical or lobar hemorrhages. Other risk factors besides those listed here include low LDL and use of anticoagulants and antiplatelet medications. This is becoming an increasingly important risk factor among our patient population as the population continues to age. The use of warfarin represents a 2 to 5-fold increase in incidence of intracerebral hemorrhage depending on INR. There are several non-modifiable risk factors for intracerebral hemorrhage as well. Among them, age is the most important. Incidence increases dramatically with age from about 6 per 100,000 in middle age to about 177 per 100,000 in the elderly. Worldwide, intracerebral hemorrhage accounts for 10 to 20% of all strokes, with variable incidence among countries, socioeconomic groups, gender, and ethnicities. Cerebral amyloid angiopathy is a disorder of small and medium vessels within the brain. Deposition of amyloid beta peptide accounts for weakened and fragile blood vessels. It is mostly a sporadic disease, but can also be associated with dementia. As the blood vessels continue to get weak and fragile, along with the other important risk factor of hypertension, the blood vessels become weak and often bleed. On MRI scan in cerebral amyloid angiopathy, we see a lot of micro hemorrhages, which are not apparent on CT scan, but are apparent on MRI with a little bit closer examination of the brain. To talk now about intracerebral hemorrhage morbidity and mortality, it carries a very significant mortality rate. At 1 month, ICH carries a mortality rate of almost 40% and about 55% at 1 year. This rate varies from country to country, with higher rates of mortality in lower income countries. The rate is also affected by the patient's other comorbid conditions. Now let's move on to in-hospital management. The majority of these patients will present to the emergency department as a code stroke or other suggestion of stroke. Once airway, breathing, and circulation are addressed and secured, the most important part of early management is an accurate history. This includes not only the onset of symptoms, but the severity of symptoms. Have they worsened, improved, or stayed the same? Other risk factors that the patient may carry, medications, recent surgery or trauma, and other general medical history. A baseline severity via an NIH stroke scale is also very critical. Once the patient is initially assessed, rapid imaging, preferably with CT scan, should be obtained. There should be no delay in imaging after initial rapid assessment. Laboratory data should also be obtained and should include a CBC, a chemistry, coags, including a PT and INR, cardiac enzymes, toxicology screen, urinalysis, and a pregnancy test in women of appropriate age. An EKG should also be obtained, but again, should not delay imaging. When it comes to imaging, a CT brain without contrast is the mainstay of rapid imaging. This will differentiate between hemorrhage and non-hemorrhage, which is essential in the evaluation of stroke, especially in the early stages. Once a non-contrast head CT is obtained, a CT angiogram should also be obtained. There's data to suggest that within the first 3 hours of onset of intracerebral hemorrhage, hematoma expansion occurs at a rate of nearly 38%. CT and CTA will help identify continued bleeding, which is the most important part of assessment, initial assessment of intracerebral hemorrhage. Furthermore, CTA will also help identify vascular abnormalities, which, if present, will greatly influence and alter management. If for whatever reason CT is not available, MRI and MRA are acceptable alternatives. However, there is a significant time difference between CT and MRI and could be crucial in the early management of ICH. So whenever possible, CT is the preferred method. Once the diagnosis of intracerebral hemorrhage is confirmed with rapid imaging, early management of ICH should focus primarily on prevention of hematoma expansion. While still in the emergency department, the most important factors to address are hemostasis, blood pressure control, glucose, and of course, quick admission. At this point, laboratory data should start to come back and home medications should be confirmed, which will then help in the continued management, early management of intracerebral hemorrhage. Now we will dive a little bit further into hemostasis and what that means in the emergency department. In the early management of intracerebral hemorrhage, the significant battle against hematoma expansion is critical, and for hemostasis, patients on anticoagulation account for nearly 20% of all ICH patients. I will touch only lightly on anticoagulation and reversal agents and leave that more for Robert to discuss later in this presentation. When it comes to warfarin use, FFP and vitamin K have been the reversal agents of choice historically. However, PCC is now the preferred agent due to not only rapid administration, but also rapid reversal of INR. Direct oral anticoagulants are ever increasing in frequency of use. When it comes to reversal, this has remained a point of hesitation for most physicians when deciding whether to put their patients on warfarin versus a DOAC for anticoagulation. There is some ease in the fact that there is no quantifiable number to reverse when using DOACs, and until recently, drug-specific reversal agents have not existed. Currently, PCC is widely accepted as the reversal of choice in most DOACs. However, Praxbind exists for Pradaxa and Dexanet for both Eliquis and Xarelto. Now to discuss a little bit further blood pressure and blood pressure management. The most important factor to address when preventing hematoma expansion is blood pressure, besides hemostasis. So after hemostasis is achieved or a plan for hemostasis is put into effect, blood pressure also must be addressed. Often these are addressed concomitantly as the two most important factors for early management of intracerebral hemorrhage. As we discussed earlier, hypertension is the most common significant risk factor for ICH. And high blood pressure is associated not only with hematoma expansion, but also with increased mortality. Multiple randomized control trials such as INTERACT and INTERACT-2 have found that it is safe to lower the patient's blood pressure to a systolic of 140 or below. And current recommendations are early and aggressive blood pressure lowering. There is a caveat with the INTERACT and INTERACT-2 in that they did not specifically look at patients who presented with a systolic of greater than 220. However, the current recommendations are to lower the systolic for patients who do present with a systolic of greater than 220, just as aggressively and early as for those who present with a blood pressure between 140 and 220. When it comes to glucose control, the data here is less straightforward. It is known that high glucose at presentation carries an increased risk of poor prognosis. There are also studies which demonstrate that hypoglycemia carried an increased risk of mortality. So the exact target for glucose is not entirely clear, and current accepted glucose targets are just to avoid hyper and hypoglycemia. Now, we move on out of the emergency department and into the ICU for continued management. Multiple retrospectives have noted a favorable outcome in stroke patients treated in specialized stroke units or neurocritical care units. As such, when patients are in the emergency department, the decision must be made whether to keep the patient at the presenting hospital or to transfer them to a tertiary care center. The decision should be made on the availability of neurologist, neurointensivist, neuroradiology, and neurosurgery. Once an ICH patient arrives to the neuro ICU, several monitoring steps are put into place. Frequent Q1-hour neuro exams by trained nurses, at least Q1-hour vitals and at least Q1-hour vitals if stability of blood pressure has been achieved. If blood pressure is not yet stable, continued blood pressure monitoring will need to be addressed. Telemetry monitoring and pulse oximetry are also recommended. Now, the next consideration in the assessment of intracerebral hemorrhage is intracranial pressure. This remains somewhat controversial in ICH for multiple reasons. The main cause of elevated intracranial pressure in ICH is mass effect from the hematoma itself, as well as hydrocephalus from obstruction due to intraventricular hemorrhage. There is evidence of a pressure gradient which demonstrates higher ICP at the area of hematoma, but not distant to the area of hematoma, thus suggesting that patients with a small hematoma and little to no intraventricular bleeding would not need ICP monitoring. However, what about the patients who with larger ICH or developing hydrocephalus? There are two ways of monitoring ICP, which include an extraventricular drain and fiber optic device inserted directly into the parenchyma. These procedures are relatively commonplace, but no procedure is without risk. In brain trauma literature, the indication for ICP monitoring is more clear. However, with ICH, it remains unclear, except in the case of hydrocephalus. In that case, an extraventricular drain is placed in the lateral ventricle for CSF diversion. The drain also allows for ICP monitoring, which is typically done on an hourly basis. Goals for ICP in this case are largely based on trauma literature. Next, we'll discuss surgical options of intracerebral hemorrhage. We, in the last slide, discussed some surgical interventions that include extraventricular drains for CSF diversion, but what do we do about the actual hematoma? Are there surgical options? So hematoma removal via craniotomy, craniectomy, or minimally invasive clot removal and decompressive hemicraniectomy for cerebellar ICH are typically the surgical options that we consider. The most reliable data exists for cerebellar hemorrhages with brainstem compression and hydrocephalus. These patients should urgently undergo decompression with removal of hematoma and insertion of EVD. A conservative approach of just EVD for CSF diversion is not recommended in the case of cerebellar hematoma with developing hydrocephalus. Early surgical clot removal for patients with supratentorial hematomas outside of the cerebellum have not been proven to improve outcomes. Minimally invasive clot retrieval also does not have clear data for improved outcomes. Now onto secondary complications of intracerebral hemorrhage, specifically seizure and seizure prophylaxis, as this is a common question. In general, seizure prophylaxis and intracerebral hemorrhage is not recommended. The overall incidence of clinical seizure during the first week following an ICH is around 15%. The risk of subclinical seizure is a bit higher at 30%. However, seizure occurrence has not been shown to worsen outcomes. Once seizure has been confirmed with either clinical evaluation or EEG, the use of anti-epileptic medication is recommended. Patients with deprecimentation out of proportion to the size and location of the intracerebral hemorrhage should be placed on EEG monitoring. Next, we move on to other general medical complications. They are a very significant source of mortality in intracerebral hemorrhage. Up to 50% of stroke death was attributable to medical complications. Dysphagia is a common occurrence in the post-stroke population, and the presence of dysphagia and silent aspiration are the leading risk factors for pneumonia. Formal swallow screens remain the mainstay of risk reduction, and in centers with formal swallow evaluation by trained speech pathologists, the risk of pneumonia due to aspiration dropped by nearly 3%. Cardiac complications are another significant risk in the post-intracerebral hemorrhage period. Along with incidents, just the occurrence of a major cardiac event, such as an MI, has been found to lead to greater in-hospital mortality rates. Once the patient has transitioned out of the ICU to the general medical floor, treatment largely focuses on continued blood pressure management as well as multimodal therapies. Physical therapy, occupational therapy, and speech therapy should continue as deemed necessary. Another major consideration is thromboprophylaxis. When to start it, and is chemical prophylaxis okay? Patients with ICH run a high risk for DVT and PE. Common practice is to begin DVT prophylaxis with SCDs at admission. The CLOTS 3 trial was a randomized controlled trial that found the occurrence of DVT was reduced when SCDs were started immediately at admission, most notably in patients with ICH. As far as chemical prophylaxis, a meta-analysis has shown that Lovenox or heparin started 1 to 6 days after admission reduced occurrence of PE with a non-significant reduced mortality, no difference in occurrence of DVT, and no hematoma expansion. In general, use of SCDs should begin immediately at admission. And chemical prophylaxis started no sooner than 24 hours after the first stable CT scan. Thank you so much, and I will now open it to questions.
Thank you, Dr. Kempler. During your presentation, we did receive a few questions from the audience. One included, what are your preferred agents for managing blood pressure, since we do know it plays such a vital role in the hematoma expansion possibility?
Yes. So preferred agents are whatever you have available. Okay. So we know that aggressive and rapid lowering of blood pressure is the best, especially in that very acute post-hemorrhage period. And so it sort of depends on what facility they're at and what's available. Obviously, first lines are things like IV pushes of labetalol or hydralazine. But for somebody whose blood pressure is pretty high, especially near the 200 range, we know, just based on experience, that they're going to require an IV drip. At that point, Cardine or Clevaprex or whatever is available. Okay. But for each facility, first line should be whatever they can get to the fastest.
Okay. Along those same lines, when a patient does have a seizure, do you have a preferred agent to use for an anti-epileptic or anti-seizure approach?
Yes. So this is also, there's literature on seizure, of exactly what to do, and then there's sort of common practice as well. Historically, Dilantin, especially phosphonatoin, has been the preferred medication for breaking, especially status epilepticus. Okay. But now with seizure being, Keppra being most common in practical use for seizure, that's often our first line. It plays really well with other medications. It also has very few side effects.
Wonderful.
It's good for patients of all ages, and can be used in not only any sort of liver dysfunction, but also renal dysfunction as well.
Oh, great. Okay. One final question that came in is, if a patient should develop a PE or a DVT in the post-hemorrhage period, what treatment options do we really have for those patients?
That's a good question. And it's also a sort of dreaded complication for those patients, as they're certainly at risk for bleeding. So at that point, there's a lot of clinical decision making that needs to go into this. If it's a DVT that has not embolized and has not become a PE, certainly there's IVC filter placement, which would be best for the patient in that post-hemorrhage period. However, if it is a PE that's could be life-threatening, so now we have two potentially life-threatening conditions, but there has been some data to suggest that there really isn't much increased risk to the patient as far as hematoma expansion once stability has been obtained, and that we should treat the PE. So often heparin is used, of course, with some trepidation, and if possible not to, that would be the best. But we have to do what we need to do to save the patient.
Thank you so much for your time today. We really appreciate it. Stay tuned for our next speaker.
Take my hand, don't let go. Look in my eyes and in my soul. Hold me close, hold me near. Please let go of all your fear. I'm not going anywhere.
Our next speaker is pharmacist Robert Holliday. Mr. Holliday completed his doctorate of pharmacy degree in 2016 from Southwestern Oklahoma State University. Among his many roles as a clinical pharmacist, Mr. Holliday serves as the Neuro critical care clinical pharmacy specialist. Today, he, in conjunction with Dr. Kempler, will be providing a lecture on acute cerebral hemorrhage management and coagulopathy reversal. Thank you, Mr. Holliday, for providing this lecture for the symposium today.
Thank you, Sonia, for that introduction. My name is Robert Holliday. I'm a neurocritical care clinical pharmacy specialist at Ascension St. John Medical Center, and I'm here to kind of complete the second half of Dr. Kempler's presentation. I'll be talking briefly about the reversal of anticoagulants and intracranial hemorrhages. For the sake of this presentation and time limitations, we're going to just mainly be talking about our oral anticoagulants that you'll see patients coming into the emergency department with. Some objectives for this presentation is we want to review the pharmacology of vitamin K antagonists and our direct oral anticoagulants. We want to outline current reversal strategies for anticoagulant-associated intracranial hemorrhages, and discuss clinical controversies surrounding andexanet alpha and our 4-factor prothrombin complex concentrates, 4-factor 10A reversal. So antithrombotic or anticoagulant-associated intracranial hemorrhages is expected to be more common with our increasing aging population and increasing rates of atrial fibrillation. More patients are being put on anticoagulants for stroke prevention. So our patients who are on an anticoagulant that end up with an intracranial hemorrhage have higher risk of hematoma expansion. With increased hematoma expansion, you have increased mortality and also worse functional outcomes. So it's really important to make sure that we can reverse these anticoagulants to help stop that expansion. So I kind of want to just throw up a little coagulation cascade. I don't really want to go through all of it. It's complicated, it's long, but I think this is a good reference to kind of show you where all of our anticoagulants work in the cascade and how our reversal agents work and where they work at. First on the agenda is our vitamin K antagonist. It's the one that's been around forever. It's warfarin. I think back in 2015, it was 12% of all of our intraparenchymal hemorrhages were warfarin associated, and 90% of all warfarin associated deaths are due to an intraparenchymal hemorrhage. I suspect that the 12% of the intraparenchymal hemorrhages related to warfarin is actually going down because of our increased use of the direct oral anticoagulants. But it's still really, really important to notice how often this actually happens. Because when someone is anticoagulated with warfarin, again, it's still risk for higher volume hematoma, has higher risk of bleeding, and increased risk of death and functional outcomes. I feel like I'm going to say that like 10 times, but it's true. So vitamin K. Vitamin K is needed to synthesize factors 2, 7, 9, and 10, relating back to that figure. Several trials have shown that administering vitamin K can correct the INR, but it might take 24 hours with just vitamin K administration alone to get an INR of less than 1.4. That's why you have to give it with the 4-factor PCC. The 4-factor PCC will allow us to drop the INR significantly within the first couple hours, and the vitamin K comes in and smooths that out and allows you to synthesize the factors to keep that INR low. The current dosage for that is 10 milligrams of vitamin K intravenously. We can give that in a piggyback, and it's infused pretty quickly. You just have to be concerned about potentially anaphylaxis reactions or some flushing, are just kind of the more common things. I think that, like referring back to Dr. Kempler's presentation, when someone comes in and they're on warfarin and you've gotten the CT, you show the intracranial hemorrhage, you're getting those baseline labs. We want to get that INR level so we can assess their anticoagulation. We can start this process of reversal. And then also speaking with, you want to combine it with the 4-factor PCC. So our 4-factor PCC is comprised of factors 2, 7, 9, 10, and then protein CNS. Protein CNS work as they help you stabilize your coagulation cascade. So it does contain small amounts of heparin. So the concern there is if you know that this patient has a potential history of heparin-induced thrombocytopenia, that you might have to look towards alternative agents. There is multiple dosing strategies with our 4-factor PCC. It can be a little controversial, but we'll kind of get into a little bit of these strategies here in just a second. One of the big advantages is historically we've given fresh frozen plasma to replace coagulation factors, but the 4-factor PCC can be administered with a smaller volume and much faster than plasma. So it doesn't have to be thawed, and it can be administered in about 15 minutes. So a couple different strategies for dosing your 4-factor PCC is you've got a weight-based dosing and you've got a fixed dose. There's been multiple studies out there. We can kind of talk a little bit through them, but just kind of want to talk, our weight-based dosing is first based on what the baseline INR is whenever the patient comes in. If you have an INR of 2 to 4, you administer 25 units per kilo with a max dose of 2,500 units. 4 to 6, you increase that a little bit higher to 35 units per kilo, and an INR greater than 6, you administer at 50 units per kilo. The American College of Cardiology's last guidelines here, or this consensus statement here in 2020, also recommends a potential fixed dose. You could do 1,500 to 2,000 units. The problem with that is redosing hasn't really been adequately studied in these patients, but if hemostasis has not been achieved, and that's something that you can consider if your institution goes with the fixed dosing algorithm for your warfarin reversal. The direct oral anticoagulants, or as I'll probably refer to them most of the time as the DOACs. The first one that kind of comes to mind is our direct thrombin inhibitor, dabigatran. So dabigatran works at direct thrombin inhibitor, but works on factor 2A. So it is a prodrug that's converted in vivo to its active form. It is hepatically metabolized into that active form. So it inactivates free and fibrin bound thrombin. It does have a half-life of 12 to 17 hours. Therapeutic monitoring is not required for this drug, but you will see an increased thrombin time and activated partial thromboplastin time, which can provide some insight into the presence of dabigatran. So whenever you are reversing someone with an intracranial hemorrhage, you can get these labs after you administer the reversal agent to kind of see if you have achieved hemostasis or not. The main reversal agent for dabigatran is idarucimab. So it's a monoclonal antibody fragment that binds to dabigatran itself, the prodrug, and the metabolites. So it prevents it from being metabolized into its active form, and it binds the active form itself. It has an affinity for dabigatran that's 350 times greater than that of thrombin, so it works very well. It binds very quickly, and it neutralizes the anticoagulant effect within minutes. This is administered as 2 separate 2.5 gram infusions. They're 2.5 gram vials that you infuse over 10 minutes. You just infuse them back to back. The rate of post-reversal thrombotic complications is about 6% in their clinical trials, just kind of a monitoring parameter to watch out for. We are either reversing, their anticoagulant by either replacing factors such with warfarin or with this, so there are going to be potential instances of thrombotic complications. Other strategies for reversal. So if you know that dabigatran's been administered very recently prior to arrival, you can give 50 grams of charcoal, and that will reduce the intestinal absorption. So that way you don't have a prolonged anticoagulant effect after you've administered the reversal agent. If idarucimab's unavailable, you can consider 4-factor PCC at 50 units per kilo. And then hemodialysis can also be considered if they're at a facility that doesn't have any reversal agents on hand. A 2-hour session of hemodialysis will remove about 60% of the drug. You just have to be careful with that because you are messing with volume status and the equilibrium and the cellular shifts of the blood. Factor Xa inhibitors, the big ones we always think of are apixaban and rivaroxaban. They're the ones that we see most common. I just kind of have them up here side by side so I can show you kind of how they work the same way. Their half-lives are pretty similar, 5 to 9 hours for rivaroxaban, about 12 hours for apixaban. They are both pretty protein bound, so that means any sort of dialysis won't really remove that much of the drug compared to like dabigatran. And again, therapeutic monitoring is not required, but you can, whenever a patient comes in, you're getting baseline labs, you could potentially see elevated levels either in their INR or their TNA level, their anti-TNA level. Edoxaban's the other one. We really don't see this very often. It's not commonly prescribed versus other agents. It works the same way. It has about the same half-life. Andexanet alpha, which is the next drug that we'll kind of be talking about here in a minute, has not been approved for reversal of edoxaban, not because it probably doesn't actually work, but because in Andexanet alpha's clinical trials, there was not enough patients to give the Andexanet alpha the approval for reversal. So kind of going into a little bit of history. So the introduction of the DOACs preceded reversal options, drug-specific reversal options, that is. PCC kind of became the workhorse for this. And there are some studies out here evaluating it. I've got a couple of them. There with a little bit of background, both the Schulman and the Majid trials, they assessed acute bleeding and included hemorrhages, intracranial hemorrhages in that. So we'll kind of talk a little bit more about it here in a minute. The newish drug that's kind of come on the market here recently is Andexanet alpha. This was the first FDA-approved drug for the reversal of the factor Xa inhibitors, specifically rivaroxaban and apixaban. So it is a recombinant engineered version of the human factor Xa molecule. So it really works as a decoy. When you compare these two figures here, they changed the serine to an alanine and eliminated to help eliminate the catalytic activity and prevent thrombin cleavage. And then they removed the GLA component there to help prevent the anticoagulant effect. So therefore, the factor Xa will just bind that instead of actual factor Xa. And which leads us to our reversal. So there's also multiple dosage strategies related to Andexanet alpha. It depends on the drug, apixaban or rivaroxaban, the dosage that the patient is receiving, and the time since they took the last dose. Andexanet alpha in its clinical trials did decrease median anti-factor Xa activity by 92% for both apixaban and rivaroxaban, maintained good hemostasis 12 hours after infusion, although they were able to measure anti-factor Xa levels 12 hours after infusion, actually saw that the levels had increased about half the baseline 12 hours post-infusion. even though they didn't really have any rebleeding, that is still something to consider. And they did have higher rates of thromboembolism. At first, it was close to 18%. I think that's come down to 10 or 11. That's come down to 10 or 11, but it's still a big monitoring parameter to watch for. That's still a big monitoring parameter to watch for in these patients. So the dosing, kind of getting into it, there's a low dose and a high dose. I kind of just try to put a chart in here to kind of talk about it. You start with a bolus, either 400 or 800 milligrams, depending on the time since last dose and the doses that they're on, and then an infusion that lasts 2 hours. The other option, I guess, as we talked before earlier, was 4-factor PCC. It is off-label use. Data supporting the use is kind of limited to observational studies. There's some prospective stuff out there, like the couple studies I mentioned earlier, but they don't have a control group. They're just prospective single-arm trials. Based on the limited data, it is reasonable to give a fixed dose of 2,000 units for severe bleeding when andexanet alpha is not available. This is widely used due to cost, depending on your purchasing contract at your institution. 4-factor PCC might cost anywhere from $6,000 to $10,000 to $12,000, where andexanet alpha might be costing $30,000 to $40,000 to $50,000, depending on the dosing strategy. A little bit of the comparative literature. So they're all kind of small studies. The Nexa-4 trial had 67 patients. The McGee trial had 84, and the Schulman had 66. You can see the percentage of those patients that had intracranial hemorrhages. They all maintained hemostatic efficacy that they define as excellent or good, which is mainly just referring to hematoma expansion. And then the thrombotic events, like I said, initially was like 18%. In the Anexa trial, I think, it's down to 11%. So Anexa-4 is still, andexanet alpha is still in like a post-marketing or a post-approval trial. It's still in a phase 4 trial that was required by the FDA that we are actually enrolled in at Ascension St. John and other institutions around the world. Next, this is the summary from the ACC expert consensus on the pathway of management of bleeding in our patients on oral anticoagulants. The one I didn't really talk about was betrixaban. It's not currently available on the market in the United States, but it also has edoxaban there as well. They recommend to give andexanet alpha with high dose, and if it's not available, to give PCC. And then also consider activated charcoal for those patients that with a recent ingestion of the medication within the last 2 to 4 hours. So in summary, warfarin requires reversal with both 4-factor PCC and vitamin K. That's kind of the takeaway there. Is always remember you need to give both of those agents at the same time or back to back to maintain hemostasis and keep that INR less than 1.4. Idarucimab's affinity for dabigatran is that 350 times greater than that of thrombin. So it's a true reversal agent. It works really well. And the Anexa-I phase 4 study will provide more insight into the safety and efficacy of andexanet alpha in intracranial hemorrhages. So hopefully we see that here in the next couple of years. And if that's positive, hopefully if it's positive, hopefully it'll convince institutionals to start switching to that as their workhorse to follow the guidelines. Here are some references. And any questions?
Thank you, Dr. Holliday, for your presentation. We had a few questions come in while you were presenting, and we'd like to take some time and ask them to you now.
Perfect.
All right. What alternative agents are available if a patient does have a history of HIT and they need their warfarin reversed?
Yeah, so at our institution, we utilize a 3-factor PCC called Profil 9 that has factors 2, 9, and 10 in it. And its dosing is based on INR, and it is weight-based dosing between 20 to 50 units per kilo, depending on what their INR is.
Okay. Thank you, Dr. Holliday, for your time. We appreciate it very much.
Oh, thank you for having me.
Stay tuned for your next presenter.
As your neighbor who works at Ascension St. John, I'm going to keep asking you, how are you feeling today? Your care can't wait. Getting care sooner can mean catching things before they get worse. At Ascension St. John, our ERs, hospitals, and other sites of care are maintaining strict precautions for your safety. Studies have shown that 63% of people say they would be encouraged by friends, family, and their doctor to get care sooner. So keep checking on them. Remind them to get the care they need at getstjohncare.com.
Our next speaker is Dr. Christopher Abdo. Dr. Abdo completed a combined doctorate of osteopathic medicine and master's of business administration at Oklahoma State University in 2013. He completed his neurology residency in 2017 at the University of Illinois at Peoria, where he served as chief resident. Today, Dr. Abdo serves as an attending physician for the Ascension St. John Inpatient Neurology Program. Today, he will be providing a lecture on prognosis after cardiac arrest. Thank you, Dr. Abdo, for your time and participation.
So I'm Christopher Abdo. I'm a neurohospitalist at St. John's Ascension in Tulsa, Oklahoma. Today we're going to discuss prognostication following cardiac arrest, primarily from the neurologic perspective. I have no disclosures to announce. We're going to be, our objectives are to kind of identify our goals and outcomes of post-cardiac arrest care and obtain familiarity with the tools that we use in order to make these prognostications, and also very importantly to learn the limitations of these tools. So when we talk about survival following cardiac arrest, we know that survival is low. Maintaining cerebral perfusion during the arrest is key to survival. We know that rhythms with poor perfusion, such as asystole and PEA, tend to have worse outcomes when you compare those to those with somewhat perfusing rhythms like BTAC and BFib. Quality of the CPR is also a factor, and also witnessed versus unwitnessed. These are things that we kind of keep in our mind early on. They serve less prognostic implications the more data that we collect and observe going forward. So when we talk about the goals of neurologic prognostication, we're trying to accurately predict who will have disabling and non-survivable deficits. Disabling injury places large burdens on families, survivors, and society as a whole. Families will experience large caregiver burdens and also financial costs. And society experiences those costs through insurance companies and through funding. And also lost production from family members who are providing care. Accurate prognostication allows for us to aggressively care for those who survive or have a good chance to survive, and avoids prolonged care in those who are unlikely to make a meaningful neurologic recovery. So when we define poor outcome, we're mostly different patients will have different opinions about what a poor outcome will be. But what we're talking about mostly is patients in a persistent vegetative state, a minimally conscious state, those with severe neurologic disability, or those who will die from their neurologic injury. our prognosis is going to be determined by a multimodal approach, meaning we're going to use multiple different tools and modalities in order to reach our conclusion. We're also going to use the knowledge and base of our colleagues in medicine, cardiology, and other specialties to help us develop, provide a whole patient prognostication. We have to be aware of the limitations and our confounding variables. We also have to be aware of our biases. Our main goal is 100% specificity in assigning poor prognosis. The most common cause of death in ICU patients following return of spontaneous circulation is the withdrawal of life-sustaining treatment. Because we assign a poor prognosis, or we assign a prognosis that of some sort of disability, patients' families will often withdraw care based upon the recommendations that we're making, and we have to avoid this self-fulfilling prophecy, which is kind of inherent in a lot of cases when we're trying to predict neurologic injury in patients and neurologic outcomes. Because we see a patient who looks very ill and has a brain that's not functioning well, we will often assign negative prognostic implications when we haven't fully made that. And when we withdraw care, life-sustaining treatment, and that patient dies, our prophecy has been fulfilled, even though we may or may not have been correct. So we're going to talk about some of the states that patients are in, that will be in. Coma is a state of unresponsiveness in which the patient is not awake and doesn't interact with the environment, even after vigorous alerting stimulation. So when you're moving, and so coma has a pretty specific definition, and that means they're unresponsive whenever you interact. If the patient grimaces or does things, they're not necessarily they're not going to be, you wouldn't describe them as being comatose. So these poor outcomes, like a persistent vegetative state, which means wakefulness without awareness. These patients can have spontaneous eye opening, sleep-wake cycles without any purposeful behavior suggestive of awareness of them or the environment. Normally, if this persists for 3 months after the arrest, it's permanent. In patients who have a traumatic brain injury, you need to wait longer. Sometimes we can mistake this for a minimally conscious state. You may require some EEG or fMRIs to fully diagnose that. Patients with a minimally conscious state will have a severe alteration in consciousness, but they may interact with their environment intermittently as well too, and may follow simple commands. Brain death is the irreversible cessation of cerebral and brainstem function. This tells us that when patients meet criteria for this, they are dead by legal and any legal. Here we're trying to kind of show a lot of the different things that go into how we make our decisions. So if we look at the values of the individual, and it helps to ask, hey, what was this individual like? What would they do? How much disability were they willing to tolerate? Are they somebody who can go through a large amount of work and challenges? How do they respond to challenges typically during their lifetime? The second part is, what is their injury burden? How much damage has been done to their brain and to their body by whatever has caused their arrest? The cerebral reserve is how much viable neurologic tissue remains. Can this patient, based upon this injury, return to a reasonable functional state? And then there's also cerebral resilience, which is how much individual a person can tolerate. A 19-year-old who has a cardiac arrest and suffers a cognitive injury and damage to the cortex might be able to survive and might be able to have a functional recovery. If there's an 89-year-old with dementia who lived at a nursing home at baseline, that patient's not going to have any resilience, and their chances of returning to any sort of functionality are going to be very limited overall. So we're going to kind of review the main tools we use to help us determine our prognosis. Neurologic examination, EEG, neuroimaging, somatosensory evoked potentials, and biomarkers. So when we talk about the neurologic exam, this is something that's kind of near and dear to my heart, but we're really going to focus on these things that help us, these evidence-based findings that help us determine prognosis. So absent pupillary reflexes and corneal reflexes. So by day 3, if these are still present, there's a very high specificity for poor prognosis. This finding is even consistent in patients who have undergone targeted temperature management. So the next part is extensor motor or lack of motor response on day 3, meaning your patients distribute an extensor posturing upon noxious stimuli, or they have no response at all. While this on day 3, this has a very high sensitivity for detecting patients with poor prognosis, it lacks specificity for several reasons that we'll kind of discuss later on. Your patients with myoclonic jerking. So one of the things that we have to talk about is that myoclonic jerking has several different etiologies. Your post-arrest can be the cause of it. Patients with myoclonic status, meaning a continuous intermittent firing from the brain itself, is associated with a poor prognosis. Different studies will define myoclonic status in different terms. There are several case reports of improvement in patients who have been seen to have early myoclonus, and the false positive rate is around 10%. The other thing we have to talk about is the Lance-Adams syndrome, and this is a myoclonus that is seen with volitional movement that you'll see in some post-cardiac arrest survivors. It's pretty rare, but we do see it occasionally, and it can be very difficult to distinguish, especially in the setting of patients on a high amount of sedation, or in patients with a severe metabolic derangements. You have to evaluate myoclonus off of sedation. A lot of times an EEG is useful in helping to determine the etiology, but you also have to remember your confounding variables as well too. A patient with a very high BUN, or a patient with liver failure may be exhibiting myoclonus because of different etiologies rather than their central causes. So you have to keep that in mind when you're assessing these patients. And the neurologic exam is susceptible to many pitfalls. A lot of the time, this is one of the most common ones is sedation. The patient is on large amounts of Versed for ventilation compliance, or they're on a large amount of propofol or different sedatives. Paralytics are basically render most of our examination useless because there's no you're not going to see any reflexes or skeletal muscle abnormalities. The only thing that one of the only things that you'll basically see on these patients' examination is you will see a pupillary response in patients who have intact pupillary reflex, because that's not mediated by skeletal muscle. It's a parasympathetic response. So you will see your patients will still have a pupillary reflex. And again, kind of like we talked about with myoclonus, toxic metabolic derangements can cause alterations in mental status and cause patients to be comatose, just as well as the cardiac arrest can. So this is another part, is that the examiner and the interpretation are susceptible to the examiner and their expertise, and they're also susceptible to their interpretation and any self-fulfilling prophecies or those types of biases. And it's also not very, some of your patients may have some response that we are not picking up on clinical examination. A patient who's locked in may not, if you're not testing for it, if you're not asking the specific questions or doing the correct things, they may not be able to respond. One study kind of showed 1 in 7 patients who are non-responsive may show evidence of response on EEG or on MRI. And you don't want this influence, you don't want the influence of this exam alone to determine your outcomes. We also have, there's one of the problems with the examination is we have a generation of neurologists who have been trained in post-cardiac arrest cases to be pretty much exclusively in the realm of targeted temperature management. And so this is going to, so most of us have been evaluating patients from this perspective on day 3 rather than day 1. Previously, targeted temperature management provided us with multiple confounding variables early on. And given its prevalence, most studies in their time have been focusing upon it. So we're going to be entering a realm of new data where we're relying on patients we haven't seen very much of before, and we're relying on studies performed decades ago to help us kind of determine how this exam, how our exam relates. That's a similar finding with EEGs as well too. Most of the data for continuous EEGs and cardiac arrest has been in the targeted temperature management phase. So we're looking at a smaller amount of data in these post-cardiac arrest patients without targeted temperature management. So we'll kind of be looking towards seeing what these things, what kind of shakes out. So we use EEG basically for 2 main purposes. One is to evaluate for seizures, non-convulsive seizures, things that we're not seeing, to make sure that certain movements or abnormalities are not seizures that need to be treated, and also to provide information regarding prognosis. We can find 3 different types of patterns, basically: benign patterns, patterns that are intermediate, and malignant patterns. These malignant patterns confer a high mortality rate, 91% overall, with some being worse than others. One of the things that we are looking for in a patient in post-cardiac arrest is reactivity to external stimuli, meaning whenever somebody walks in a room or does suctioning, applies noxious stimuli, that we see some sort of pattern or reaction from the EEG patterns. Usually you'll see some type of slowing or things that we can define as reactivity. A lot of times this is kind of hard. This may be hard to see, and it's interpreter dependent in a lot of ways, because there's not a great definition of it within the literature. And sometimes it takes an extended EEG to be able to kind of determine if the background is due to some sort of artifact or due to that reactivity itself. But reactivity is typically a good neuroprognostic finding. Malignant findings are typically seen seen as poorly prognostic. Generalized suppression at less than 2 microvolts, meaning that EEG just looks very flat, is the most specific finding for poor prognosis. A burst suppression pattern is typically seen as a poor prognostic value. Now, this can be confounded because a lot of these patients are on sedative agents that can lead to a burst suppression pattern, like propofol, like midazolam. However, most of the time we'll be able to see some things that will distinguish a benign burst suppression pattern from a malignant one, but we can't be too sure. The best way to kind of be assured of that it isn't confounding your EEG is to have your sedation off during the EEG, or have a sedative that isn't going to impact your EEG as much. Precedex does seem to have some impact on the EEG, but much less so than you won't see a burst suppression pattern with Precedex, but like you would with Versed or propofol. Status epilepticus is typically termed to be a near universal mortality, but there are lots of case reports of patients who have recovery following status. And one of the things that was kind of noted is that those patients also had a reactive background, that positive prognostication from before. So it would be more accurate to say patients who have status with a non-reactive background have near universal mortality. Also, whenever we see generalized periodic discharges, those are typically thought of to be of negative prognostic implications. So EEG pitfalls. Overall, EEG has poor validation in terms of cardiac arrest because there are so many different, the studies that we rely on have different recording links, different classification systems, different definitions of things like myoclonic status, different definitions of things like reactivity. And there's also a lack of standardization and stimulation modality with which we determine reactivity. Meaning, one institution may do flashing lights, one institution may do a method of accelerating stimuli. It just kind of depends. There's poor observer reliability in terms of, and because of the lack of classification systems. Things like the Salzburg criteria and more standardization of reporting on EEGs is kind of narrowing it down, but we're not past that modality, not past those problems at this time. Most of our cardiac arrest data, especially the continuous data, is from the targeted temperature management era, which is kind of tapering off. It is impacted significantly from toxic metabolic influences, medications, kind of like we talked about, before, the propofol and Versed. Withdrawal from medications such as baclofen can cause a lot of abnormal findings, metabolic derangements, sepsis, hemodynamic instability. All of these things can contribute and impact the EEG overall. And your patterns may evolve over several days as well, too. Your EEG is a snapshot of your brain working of the brain's function at that specific time. And it may change over time dependent upon kind of all of those prior factors. The next part we're going to talk about is SSEP. So what is the SSEP, or somatosensory evoked potential? Basically, it measures activity in the somatosensory cortex following electrical stimulation of a peripheral nerve. So they go down to the median nerve and they send an electrical signal back up through the dorsal root ganglia into the posterior columns, the cuneate nucleus, and back into the medial lemniscus. which goes back into your thalamus and then into the somatosensory cortex, where we measure that electrical activity. So basically what it tells us is that the pathway from the median nerve to the cortex in the brain is intact if you're getting that signal. Its utility is actually pretty good. So absent responses at 24 to 72 hours post-arrest confers poor prognosis with a very high specificity in the high 90s. Its problem is with its sensitivity. Early responses may disappear after several days. Almost half of those who have an intact N20 signal, which is that main signal that we're measuring, will die without recovering consciousness. Many studies will report 100% specificity, but there are some studies where false positives were noted. Targeted temperature management may confound this. We're not doing this as often anymore, but it slows the conduction velocities and may impact prognosis in a small set of patients. In one study, one patient out of 36 had an absent N20, but still recovered. Interobserver reliability is usually pretty good with SSEP, but it can be impacted when there's a lot of noise or a lot of artifact, which is going to be a significant factor especially in cardiac ICUs and in the patients that we're seeing. The other modality we're going to be relying upon is neuroimaging. The first thing that you're typically going to get is a CT of the head, and this is almost always going to be normal early on post-cardiac arrest. The main reason that we need this study is to rule out other causes of the cardiac arrest, like an intracranial hemorrhage or a subarachnoid, meningitis, those types of things. Sometimes I see this step skipped occasionally, and it's a very important test. Because a lot of the time, these patients are going to be going on antiplatelets or anticoagulants, and you don't know what's caused the arrest or has contributed to it. The sensitivity of this increases greater than 24 hours following cardiac arrest, but this and it's going to show you it's going to detect a severe injury at a very high rate. Cortical injury, some cortical injuries, mostly impacting the outer cortex, that can cause significant disability. You may not see those on the CT scan, while the patient's hospitalized. Overall, it has very poor sensitivity, but when you see the changes, when you see changes consistent with hypoxic ischemic injury on a CT of the head, it has a very, very high specificity. When you talk about a decreased gray to white ratio, you have a nearly 0% false positive rate. One of the things that you have to take into account is that when they do these studies, they're typically performed with neuroradiologists, radiologists who are very comfortable interpreting and making those determinations of hypoxic ischemic injury. If you're not working with a neuroradiologist or somebody who's very comfortable with that, your false positive rate can probably increase. And we've seen cases before where these studies have been incorrectly interpreted, or they have mistaken, or we have mistaken something for something else. Focal effacement is suggestive of severe injury and edema in the brain, and this is another finding that is associated with poor prognosis following arrest. Magnetic resonance imaging, especially the diffusion-weighted imaging, or along with the ADC map, is highly specific for poor prognosis when patients have abnormalities in greater than 10% of the brain. Timing of this test is important. 36 to 96 hours following arrest is the most sensitive and specific time for MRI. If you do MRI too early, especially less than 24 hours prior following the arrest, it may not show that injury, and you may miss important data there. If you go beyond 96 hours, sometimes those changes in the diffusion weighted sequence will kind of disappear. So the timing of this test is important. Now, if you have a very severe injury, the MRI is going to show those findings. But for your cases who are more indeterminate, the 36 to 96 hours is where you want to shoot to get that MRI done. There are some investigational things, PET and functional MRI, where we're seeing the patient's response to stimulation. These are all investigational. They require a lot of different interpretation, and they haven't been standardized at this point. We're not really using too much of those. We use EEG as a pretty big surrogate of this in patients in the hospital. Other biomarkers such as neuro-unspecific enolase and S100 protein are occasionally used. They have pretty good data in terms of their sensitivity and specificity. Targeted temperature management it does impact the amount of NSE, especially in the serum. They aren't very useful to us typically because of the long turnaround time. They don't run this test in the labs at St. John's. They have to send these to an outside, and it's more than a week before you're typically getting these labs back. So they're typically not very useful to us kind of overall. So when we put these tools together and attempt to provide our patients, families with the best prognostic information that we can kind of tool together, and we have to be aware of the limitations of each of these tools and not rely on one, and not rely too much on one of these modalities. All right, those are our sources. Thank you.
It is with great honor that I may now introduce Dr. Carlos Esada. Dr. Esada and I have been colleagues since our days of training at the Cleveland Clinic Foundation. He is one of the most brilliant minds I have ever known. He is currently the Vice Chairman of the Department of Infectious Diseases at the Cleveland Clinic and specializes in neurological infectious disorders. While in the midst of a COVID pandemic, he is here to educate and update us on the pathophysiology of COVID and vascular disease. Ladies and gentlemen, Dr. Esada.
Good afternoon. My name is Carlos Esada, and I come to you from the Cleveland Clinic in Cleveland, Ohio, from the Department of Infectious Diseases and the section of Neurologic Infectious Diseases. It's my honor to speak with you today regarding the neurologic complications of COVID-19. I'd like to thank the organizers of the symposium and Dr. Daryl Thompson for his invitation today. I have no conflicts of interest. Our outline today will be to start with a little bit about the timeline of the pandemic, a bit about the SARS-CoV-2, the virus itself, pathogenesis, neurologic manifestations of COVID-19, with an emphasis on cerebrovascular disease, and then a few frequently asked questions at the end. This map is from the Johns Hopkins Coronavirus Resource Center. As of October 9, 2021, the worldwide cases were over 237 million, the U.S. cases over 44 million, and the U.S. deaths over 712,000. The main cause of these deaths is respiratory failure, usually accompanied by the adult respiratory distress syndrome, or ARDS. In addition, autopsy studies have shown both macrovascular and microvascular thrombosis. This involves all organs and not just the lungs. The arterioles, capillaries, and venules are involved, and the thromboses consist of platelets, fibrin, red blood cells, and white blood cells. So it's apparent that SARS-CoV-2 not only infects airways, but also induces vascular disease. This study from Ackerman et al. From Hanover, Germany, was early in the pandemic. This was an autopsy study which compared the 7 lungs of patients who had died from COVID-19 versus 7 lungs of patients who died from influenza versus 10 uninfected control lungs. All the patients here had died from ARDS. Pathologically, there was diffuse alveolar damage with perivascular T-cell infiltrates. The lungs from the patients with COVID-19 had distinctive vascular features, such as severe endothelial injury, and some had intracellular virus detected. There were widespread thromboses with microangiopathy, and on this H&E stain here, you can see lymphocytic infiltrates, some of which were perivascular. There was also widespread thrombosis with microangiopathy. And here is the interalveolar septa, and the arrows here point to microthrombi within the capillaries. The alveolar capillary thrombi were 9 times more prevalent in the lungs of patients with COVID-19 than those who had influenza. And interestingly, there was also angiogenesis, which is new vessel growth, two times as common as with influenza. The virus itself, SARS-CoV-2. This is an enveloped single-stranded RNA virus. At least 6 coronaviruses have caused human disease. One of the first major outbreaks was in 2003 from severe acute respiratory syndrome, or SARS-CoV, the original one in 2003, followed by the Middle East respiratory syndrome, or MERS, in 2012. It was interesting that both of these viruses, both the SARS-CoV and MERS, were noted to have neurotropism. There are 4 key structural proteins in SARS-CoV-2. There is a spike surface glycoprotein, here, S, named spike. This initiates attachment of the virus to the host cell receptor. There's also a membrane protein, here, M. Envelope protein, here, E. And the nucleocapsid protein, designated as N. Important host receptors are the angiotensin converting enzyme 2, or ACE2, and another one called TMPRSS2, which is a transmembrane serine protease, which is important in binding, which I'll show you in a minute. And other host receptors are important too. So ACE2 and the TMPRSS2 are both needed for the virus to enter the host cell. And here is the TMPRSS2 in the host cell membrane, as well as the ACE2 receptor. And the spike protein in step 1 binds to ACE2. Then the TMPRSS2 cleaves the spike protein between the 2 subunits. The viral membrane then fuses to the cellular membrane, and the viral RNA is injected into the cell. This is the life cycle of SARS-CoV-2 as it infects the cell that has an ACE2 receptor and a TMPRSS2 receptor. It enters through here through a process of endocytosis, at which point there is viral RNA replication, and it goes through a variety of processing steps to mature. So you have virus maturation and then exocytosis of additional virions. What also happens is there are a number of different cytokine-mediated steps, such that going through an intermediate IRF3, it goes into the nucleus of the cell where there is transcription which occurs of a number of different pro-inflammatory cytokines. This also comes about through a second pathway where the spike proteins that come off of the virus can enter and interact through toll-like receptor 4 on the cell surfaces. And it goes through a variety of different intermediates, TRAM, TRIF, MyD88, and then they essentially enter the cell and stimulate an important intermediate called NF-kappa B, which stimulates messenger RNA production also of a wide variety of pro-inflammatory cytokines. One of the most important ones here is interleukin 6, and these are pro-interleukin 1, and these come out with interferon alpha, which is stimulated, that goes into another pathway. So it's a complex pathway where inflammatory cytokines are produced as a result also of the viral replicative process. Some of our treatments for SARS-CoV-2 are actually options which are based on this pathogenesis. Some of our treatment options currently are one, a direct antiviral, which is remdesivir. This is U.S. Food and Drug Administration, FDA approved. But there are also monoclonal antibodies to the spike protein. The FDA has approved these monoclonal antibodies for mild to moderate COVID-19, as well as some cases of qualifying post-exposure prophylaxis. This includes casirivimab and imdevimab administered together, and bamlanivimab and etesivimab, which also are administered together, and there are others. Another group are the immunomodulators. These are not FDA approved, but they are available in the United States through the Emergency Use Authorization, or EUA. And this includes one which is used quite commonly now, tocilizumab and sarilumab. These are IL-6, interleukin-6 receptor monoclonal antibodies. And there's other IL-6 monoclonal antibodies, and also anakinra has been looked at, which is currently available for rheumatology indications such as rheumatoid arthritis. This is an interleukin-1 inhibitor, again, one of the cytokines that was produced. And there's also a family of inhibitors called Janus kinase or JAK inhibitors, which are produced at that later stage as well. The ACE2 receptors themselves are widely expressed. These include many areas of the body. In this diagram, the green mean where there's ACE2 expression, and the red mean where there's ACE2 deficiency. So you can see there's some areas where it is both deficient, but it's actually widely expressed, including the central nervous and peripheral nervous system. Neuroscientists have used this knowledge about the ACE2 receptor distribution to help elucidate the viral pathogenesis, knowing that the ACE2 receptors are present in neurons, astrocytes, microglia, and oligodendrocytes. It's been helpful to know how these are distributed in the brain, again, including the olfactory bulb, substantia nigra, the ventricles, areas of the middle temporal gyrus, but also the brainstem has been involved with the ventrolateral medulla, nucleus solitarius, and parts of the vagus, particularly the motor nucleus. Mechanisms of the neurologic involvement in COVID-19 are likely multifactorial, and both direct and indirect injury can occur. In this schematic by Jha, this is part of the various injuries that can occur associated with neuroinvasion. So there's a hypoxic injury, an immune injury, as well as direct infection injury. Regarding the hypoxia injury, this is the most common form with ARDS patients who are intubated on high FiO2s. Of course, there's an increase in anaerobic metabolism, also increase in acid metabolites. This can lead to a variety of downstream problems, most common atoxic encephalopathy. Immune injury can also occur associated with the so-called cytokine storm that we've been discussing, going through a systemic inflammatory response syndrome, leading to a similar encephalopathy picture. Regarding the direct infection, it's probably two different pathways. One is through a direct blood circulation cascade where virus has to cross the blood-brain barrier at some point. And then and causing this type of acute viral encephalitis and also encephalopathy. But there's also a pattern where it can go through a neuronal cascade and cause injury through a demyelination type of injury. So that's where you might see white matter disease, i.e. leukoencephalopathy. Regarding the possibility of direct viral invasion into the brain, there have been several different possible entry points that have been hypothesized. So one is through the nasal route, the blood-brain barrier, and also the choroid plexus or the blood CSF barrier. Regarding the nasal route, the virus here is inhaled through droplets, and most of this goes towards the lung for causing pneumonia. But it's possible also that it may attach to the nasal submucosal tissue, which is highly vascularized. And also it can track along the olfactory nerve, pass through the cribriform plate, olfactory bulb, and at least potentially in that route into the brain. Another is the vasculature route. So from the highly infected lung, oxygenated blood goes to the heart and then passes into the vasculature towards the brain, at which it is within the blood-brain barrier or the neurovascular apparatus. So here is the blood vessel consisting of an endothelial cell, which has a tight junction, which comprises the blood-brain barrier. There's also parasites around this as well. And then the foot processes of the astrocytes, further solidifying the barrier. Now the virus is within the lumen, and at least potentially, because the endothelial cells do have ACE2 receptors, it can potentially go attached here, pass through the ACE2 via ACE2 and attach to the ACE2 that's also on the neuron, and in that way go into the brain. Finally, another speculated area is through the choroid plexus here. So in this cartoon, here's the blood and the CSF. The SARS-CoV-2 can potentially go through fenestrations in the endothelial lining. And then because the epithelium of the choroid plexus does contain some ACE2 receptors, it can potentially go through this route into the CSF and probably not enter through the tight junctions unless there's an ACE2 receptor which is present. One caveat is that although these mechanisms seem logical and appealing, it has been difficult to demonstrate any of them scientifically. For example, although ACE2 receptors have been demonstrated on endothelial cells comprising the blood-brain barrier, there is no specific scientific evidence to date that the ACE2 receptors actually mediate viral entry into the brain. We know that SARS-CoV-2 does enter the brain of some patients. Autopsy studies of patients dying of COVID-19 have detected virions in brain tissue in some patients. However, these findings do not correlate well with the severity of neuropathologic findings, bringing up the issue of whether the finding of the virions is clinically significant. It seems that SARS-CoV-2 is not usually neuroinvasive, not like other viruses such as herpes simplex, the cause of herpes simplex virus encephalitis, West Nile, and other arboviruses. The number of cases of invasive encephalitis from COVID-19 seem to be quite few. With this theoretic background in mind, let's look at some of the clinical information. This report is from Mao et al. That was published in the Journal of the American Medical Association. This was the first major report of neurologic manifestations of COVID-19. This came very early in the pandemic and was an observational retrospective study looking at cases from January 16 to February 19, 2020, very early, even before the lockdown in the United States. They looked at 3 centers in Wuhan, 214 consecutive hospitalized patients with laboratory confirmed COVID-19. Patients were divided into severe and non-severe based on their pulmonary status. They estimated about 36% of patients had some type of neurologic symptoms. Patients with more severe pulmonary infection had more neurologic manifestations. Following this report, there were a number of different case series from numerous countries that looked at the neurologic complications of COVID-19. These were reviewed by Guerrero et al. Recently, where the group looked at original published studies from December 2019 through June 30, 2020, where they reported on patients with confirmed COVID-19 with neurologic involvement. There were 143 studies which were reviewed, and one limitation was that these were observational and descriptive studies only. The total N was over 10,000 individual patients. The prevalence of CNS involvement ranged from 22 to 36%. The mortality rates were not explicitly reported, likely due to incomplete follow-up. 1,633 patients had a specific nosologic diagnosis involving the CNS in about 86%. 43 involved the peripheral nervous system, or about 13%. The remaining 9,000 patients had neurologic signs or symptoms, but these were not attributed to a specific clinical condition. These were looked at in terms of the clinical condition, and for the central nervous system group, encephalopathy was the most common, about 60%. Several categories for stroke, including unspecified stroke, ischemic stroke, and hemorrhagic stroke, with the most common being an unspecified stroke type, about 25%. Encephalitis was actually uncommon, 1%. Acute disseminated encephalomyelitis, or ADEM, was 0.2%. And venous thrombosis and multiple sclerosis exacerbation was much less than 1%. Of note here, when reporting these percentages, the denominator in this study was the total number of patients with a well-characterized clinical condition, not the overall prevalence, i.e., not all patients with COVID-19. Looking at those who had diffuse symptoms or diffuse compromise, they termed it, psychiatric symptoms were a fair number of the patients, followed by headaches, dizziness, consciousness impairment, delirium, nausea and vomiting they included, nuchal rigidity in a handful, and nonspecific combination of signs and symptoms. For the focal deficits involving central nervous system, the most common was extrapyramidal disorders of 279 patients reported, cortical spinal tract impairment, followed by some cases of ataxia, dysarthria, amnesia, aphasia, monoparesis, central facial weakness in 5, myoclonus in 5, and homonymous hemianopia in 4. Seizures were present in 346 patients. Non-specified was the most common, followed by generalized. There were 6 cases in the literature of non-convulsive status epilepticus, focal seizures, a handful, seizure-like events, and non-epileptic convulsive syncope, 1 case report. Regarding peripheral nervous system clinical conditions, so well-defined conditions, Guillain-Barré syndrome, there were 22 reports in the literature, which were 51% of the peripheral nervous system cases. Other cranial nerve disorders, 27%. Facial palsy or Bell's palsy, 11.6%. The Miller-Fisher syndrome was in a handful of cases, 4 cases, with a total peripheral nervous system reports over that time period of 43. Regarding the presenting signs and symptoms of the peripheral nervous system, the most common was smell or taste impairment, which were 746 reports, or 52% of the patients, followed by small numbers of visual impairment, oculomotor impairment, facial palsy, and other cranial nerve impairment, about 30 cases of that. There were some cases of peripheral neuropathies involving trunk and limb, 353 worldwide, dysautonomia in 27, nerve roots and plexus disorders, about 145 cases in the literature, myopathic involvement, 102, and the total patients with peripheral nervous system signs and symptoms reported were 1,400. In the same study, they looked at all the case reports during that time period that had cerebrospinal fluid findings reported. CSF was obtained on 37 patients with CNS involvement. Usually this was a low-grade pleocytosis with a range of the CSF WBCs of 0 to 46 cells per microliter. The CSF protein was normal to mildly elevated with a range of 19 to 190 milligrams per deciliter. Patients with inflammatory disorders tended to have higher increased CSF protein levels. For example, the few patients who had meningoencephalitis, the CSF protein was 466. And there was one, the highest one reported was 507 milligrams per deciliter in a patient who had a brain vasculopathy associated with COVID-19. CSF polymerase chain reaction, looking specifically for SARS-CoV-2, was positive in 4 of 25 patients and not done on 8. Regarding CSF on patients who had peripheral nervous system involvement, there were 22 which were performed. Generally, the WBCs were low, again, 0 to 9 cells reported. The CSF protein ranged from 40 to 193. And the polymerase chain reaction, looking specifically for SARS-CoV-2, was positive in 0 of 15. There are several international registries in progress recording the neurologic manifestations of COVID-19. Most of these are retrospective. These registries generally support that there is this wide spectrum of disease associations. There are some differences in the specific neurologic disease frequency, though. I point out one called the ALBA COVID registry, which is from Spain. They reported on their initial registry participants from March 1 to April 1, 2020. This consisted of 841 hospitalized patients. 57% in their registry had neurologic symptoms higher than the meta-analysis. They point out a few interesting cases. One was this one here, which was a case of encephalitis with these flare images showing bitemporal mesial hyperintensities, much like herpes simplex encephalitis. This patient did undergo CSF analysis, which was normal, and a PCR was sent for the SARS-CoV-2, which was negative. Another case from the ALBA COVID registry. This is a flare image of a patient who had posterior reversible encephalopathy syndrome, or PRESS. And on the gradient echo, there are several areas of hemorrhage. Another important case series was from the National Hospital in Queen Square in London, UK. This was notable because there were much more detailed evaluations of patients than in many other series. They had more MRIs and more CSF studies than almost all the prior studies. The numbers were modest, about 43. These were reported from April 9 to May 15, 2020. Of this group, of note, they noted 10 patients who had acute parainfectious encephalopathy with psychosis, spontaneously improving encephalopathies in 8, other neuroinflammatory diseases in 8, and stroke in 8, as well as 9 other patients. Here is another example of a patient with autoimmune para-post-infectious syndrome. These images all represent a single patient. There are extensive confluent areas of T2 hyperintensity, as noted here. Here's T2, another T2 at a different level, with corresponding hemorrhage on the SWI images here and a different level here. On the diffusion restriction, there is diffusion restriction in areas of the basal ganglia, the insula, the left occipital area, as well as the upper pons is demonstrated here. And on the T1 with contrast, there is slight contrast enhancement in these same areas here and in here. Here's another patient. This is all a single patient here who has acute disseminated encephalomyelitis, or ADEM. Here, there's extensive confluent white matter involvement here, almost a so-called tumefactive lesion in white matter involving the right cerebral hemisphere, extending into the corpus callosum on the right side and into the corona radiata. There's mass effect and some subfalcine herniation. On these arrows here show some clusters of medullary veins here and here. There is some peripheral rim enhancement on the T1 with contrast, as shown here, and some areas of another level of the T1 with contrast with some contrast blushes there as well, post-gadolinium. This is the same patient where there was histopathologic information. This is the hematoxylin and eosinophil, which shows this is primarily a white matter tissue with scattered small vessels. There's surrounding infiltrates of neutrophils and occasional foamy macrophages. This might be difficult to see, but there is a foamy macrophage there, which is extending into the parenchyma. No vasculitis or fibrinoid wall necrosis is present. There's a few perivascular T cells in the white matter, but the cortex is normal, which is not shown here. This panel here is the CD68 macrophage stain. This confirms the finding of foci of foamy macrophages. These are all in the white matter, mainly surrounding small vessels. And this panel shows the myelin basic stain, SMI 94. There are areas with focal myelin debris and macrophages. These are around vessels in white matter here, and there's a small amounts of early myelin breakdown. You can see here small amounts within the lumen, which are consistent with ADEM. Here's another example of a different patient who has acute disseminated encephalomyelitis. These are T2 weighted images. This sagittal shows a high signal intensity intrinsic to the spinal cord. And here on the axial, there's extensive high signal intrinsic T2 signal. And this is after 26 days. You can see this more confluent area has decreased 26 days later. And the spinal cord lesions appear less confluent and more discrete, and shown two discrete areas here on the axial as well. This is a different patient. These are all from the same patient who has cerebral infarction and pulmonary embolism. This is a CT pulmonary angiogram, which shows clot, large emboli in the right, and then the left pulmonary artery. This is the diffusion restriction, where there is a large area of diffusion restriction here. This is the T2 FSE with the hyperintensity in the left basal ganglia and the cortical territory of the left middle cerebral artery. Susceptibly weighted imaging shows some hemorrhage in the left basal ganglia, right here, and a long intravascular thrombus in a sylvian branch of the left MCA, which is right there. A different patient from the same cohort. This demonstrates cerebral microbleeds. This is a CT of the chest that shows ground glass opacities consistent with COVID-19. From here, there are numerous small cerebral microbleeds in the temporal, the frontal parietal lobes, mainly at the gray-white junction. The literature regarding the neurologic complications of COVID-19 continues to expand. There have been several meta-analyses of the neurologic manifestations. One recent one was by Vitala Kumar, whose group reviewed studies published through December 3rd, 2020. This included over 59,000 titles and abstracts by that time, which were screened through eligibility criteria down to 240. At this time, there were now some prospective observational cohort studies in addition to the retrospective cross-sectional and case-controlled data from previously. Encephalopathy was the most common CNS manifestation in this meta-analysis, with a pooled proportion of 23% versus encephalitis, meaning that there is some inflammation present, of 0.6%. Cerebrovascular disease had a pooled proportion of 9.9% and an estimated pooled prevalence of about 1%. This included ischemic stroke, hemorrhagic stroke, rare cases of cerebral vasculitis, cerebral venous thrombosis. However, as expected, the heterogeneity of the studies was high, with an I2 value 90% and above, indicating there was a significant publication bias, which was measured by funnel plots and Egger's test. Here are the pooled data with summary estimates from 0 to 50%. Fatigue and malaise were the most common, followed by olfactory and gustatory dysfunction. Encephalopathy was next, somewhere around 19-20%, followed by myalgias, arthralgias, general alterations in mental status without any nosologic disease, sleep disorder, headaches, confusion, cardiovascular disease, again, somewhere around 9.9%, 6% or so of Guillain-Barré, vomiting, dizziness, movement disorders, a few percent of seizures, and then very rare cases of encephalitis. Over the next few minutes, I'd like to review some of the cerebrovascular manifestations of COVID-19 in a little more detail, beginning with stroke. Some of the initial concerns regarding stroke were that the prior coronavirus outbreaks were associated with strokes, such as the 2004 SARS-CoV-1 outbreak in Singapore, which was associated with large vessel stroke. Early data from Wuhan estimated incidence of stroke in hospitalized patients was approximately 5%. The youngest patient they reported then was 55 years old. But then came an important report in the United States in May 2020 of 5 young patients with large vessel stroke. This was a paper in the New England Journal from Mount Sinai in New York City, where they were large vessel strokes as the presenting feature. In young individuals, there were 5, ages 33 to 49 years old. 4 were previously healthy. Their initial NIHSS score was 13 to 23, with a time to presentation of 2 to 28 hours. 4 had a reduced level of consciousness. Some of the neurologic deficits included focal motor problems, speech mainly, such as hemiplegia, facial droop, homonymous hemianopsia, dysarthria, gaze preferences, and dysphagia. The territories reported were the right internal carotid artery, left MCA, the right PCA, the left MCA, and the right MCA. 3 had no respiratory symptoms. A little bit about the stroke epidemiology. The risk of stroke may increase with more severe COVID-19 infection. With a mild illness, the risk is less than 1%. With severe illness and ICU stay, the risk can approach 6%. Strokes usually are about 1 to 3 weeks after the start of the COVID-19 symptoms. Stroke as the initial symptom seems to be uncommon, unlike that initial report from Mount Sinai. COVID-19 was an independent risk factor for in-hospital stroke. In one case control study with matched controls with stroke from the prior year, the odds ratio of a stroke was 20.9. Mean age of stroke is similar between those with COVID-19 and those without. And again, the young persons with a stroke seem to be actually a minority. Most patients with ischemic stroke associated with COVID-19 are actually older and have traditional vascular risk factors. One important issue is cryptogenic strokes. About 50 to 60% of ischemic strokes associated with SARS-CoV-2 are cryptogenic, meaning no traditional stroke risk factors and no etiology. In one meta-analysis of cohort studies, the SARS-CoV-2 infection had an increased odds of cryptogenic stroke compared to non-infected contemporary or historical controls with an odds ratio of 3.98. This brings up the issue of whether there might be a novel mechanism such as hypercoagulability, inflammatory thrombotic states, etc., to explain all these cryptogenic strokes. One caveat is that so-called cryptogenic might also reflect incomplete workups due to patients being critically ill, who cannot undergo imaging, insufficient follow-up, etc. Pathophysiology relates to this issue of cryptogenic stroke. COVID-19 and thrombosis. Thrombosis is common in COVID-19 with rates of arterial thrombosis approaching 3 to 4%. There are also case reports of unusually aggressive thromboses, and there are also a signal of possibly higher rates of reocclusion after thrombectomy. There are also frequent elevations in D-dimer, which reflects clot turnover. Markedly elevated D-dimer levels are reported in some patients with ischemic strokes. Generally, it's agreed that the first step in thrombosis is activation of the innate immune system in this setting. The first line host response to viral infection in general is the innate immune system. The SARS-CoV-2 stimulates activation of numerous cells and mediators. One important one is intravascular tissue factor, or TF. Also activated and stimulated are platelets, endothelial cells, and an important conglomerate called neutrophil extracellular traps. The innate immune system then interacts with the coagulation pathway. This has led to this concept of immunothrombosis. During cytokine storm, interleukin-6, IL-6, and C-reactive protein levels are highly elevated. Now, both of these are associated with increased stroke risk, even in healthy persons. Elevated IL-6 can lead to a hypercoagulable state. IL-6 induces tissue factor from macrophages, endothelial cells, and neutrophils. It also activates the endothelial cells, generates acute phase reactants, mainly from the liver, and fibrinogen from hepatocytes. Platelets become hyperactivated and aggregate. Now, tissue factor levels are markedly increased in the lung in those patients who have cytokine storm with COVID-19. The tissue factor then interacts with the extrinsic coagulation pathway, combined with factor 7A to form the tissue factor 7A complex, which looks something like this in our normal coagulation cascade. There is an intrinsic pathway and an extrinsic pathway, which lead to the common factors of 10 to 10A and generate down the normal coagulation cascade for 13 to 13A, mediates fibrin to cross-linking of fibrin and clot formation. Tissue factor actually stimulates the extrinsic pathway and then generates the cross-linking of fibrin at the bottom. Platelets are also important in acute thrombus development in COVID-19, both in the microvasculature and the large vessels. Platelets are activated directly by viral infection, also by von Willebrand factor, the neutrophil extracellular traps, and other molecules. The activated platelets express adhesin receptors, including P-selectin, and stimulate release of chemokines that recruit innate immune cells. Endothelial cell infection and injury also contributes to thrombosis. There's a direct cytotoxic effect on endothelial cells and indirect mechanisms that lead to endotheliolitis. Endothelial disruption leads to more activation of tissue factor, inhibition of fibrinolysis, and activation of complement. There's elevated von Willebrand factor antigen in blood, which does correlate with disease severity. So this thrombotic mechanism is actually very complex and involves activation of the coagulation pathway, as we went over, but also inhibition of the fibrinolytic pathway, activation and interaction with the complement pathway, and numerous other potential factors. However, the precise mechanisms of thrombosis in COVID-19 truly are not known yet and are under intense study. One other important issue is cardioembolic stroke in COVID-19. This is an additional mechanism of stroke. Cardiac involvement can be through several mechanisms, including direct infection of myocytes, cytokine storm in some patients, and general critical illness. These can lead to heart failure, arrhythmias, and even myocardial infarction, which predispose to cardioembolic stroke. Now, about 10% of patients with COVID-19 have been shown to have decreased left ventricular function. Cardioembolism as a cause of stroke in COVID-19 has been variable, though, generally lower than acute thromboses through more traditional mechanisms. Clinical aspects of stroke. This is an important study called the Multinational COVID-19 Stroke Study Group. This is a multi-phase study, which is prospective and observational. It's the largest study on stroke in COVID-19 to date. The goals are to estimate the risk of stroke in hospitalized patients and to describe features of the cohort. These are the primary outcomes, particularly risk of large vessel occlusion, or LVO, the stroke severity using the National Institutes of Health Stroke Scale, or NIHSS, the stroke subtype as measured by TOAST criteria, which is the trial of ORG 10172 in acute stroke treatment. Here are the results. There were 32 countries involved and 136 centers, 323 acute ischemic stroke, 91 intracranial hemorrhages, and 18 cerebral venous thromboses, totaling 432 patients with stroke. The demographics were 58% men, mostly older, 65 years, plus or minus 15. 24% were less than 55 years, though, and 24% had no comorbidities. And in 38%, stroke was the first presentation. Of the acute ischemic strokes, 323, disposition was 43% went home, 27% went to a nursing home or other facilities, and 30% expired. Using the TOAST criteria, large artery atherosclerosis was 33%. Cardioembolic in this series was fairly large at 27%. Small vessel occlusion was small at 10%, and an undetermined fraction was fairly significant, again at 22%. Large vessel occlusion was 45%, and it was noted that in countries that have higher health expenditures, endovascular thrombectomies rates were higher, and the NIHSS scores were lower. There were a relatively high number of young acute ischemic stroke patients with male predominance. Asymptomatic SARS-CoV-2 was in over 1/3. Large vessel occlusive strokes were more common than small artery occlusion and lacunes. IV thrombolysis was performed on 13% of acute ischemic stroke patients, and 7.4% underwent mechanical thrombectomy. These were numbers similar to early reports from the Global Stroke Registry. One other interesting recent study of stroke was involving vessel wall imaging. In this one small study, MRI with vessel wall imaging showed vascular changes consistent with inflammation of intracranial arteries in most of the patients in their series. This was exploratory, and the value added was unclear. This is one example of their patients where there is an anterior cerebral artery territory stroke on diffusion weighted image here with vessel wall enhancement of an azygous branch of the A2 segment of the ACA. Some additional points regarding stroke and COVID-19. Multiple vascular territory infarction is common, almost 26% in one series from Italy. Stroke in the vertebro-basilar territory was common, 35% in the same series. MRI and stroke may show other incidentally detected abnormalities such as PRES or posterior reversible encephalopathy syndrome, leptomeningeal enhancement, and others. All-cause mortality after stroke seems to be higher with COVID-19 than without it. Utilization of stroke care in general has decreased significantly during the pandemic. Regarding the stroke management in COVID-19, for the diagnosis of stroke, screen all patients suspected of stroke for COVID-19. Usually this may already be part of hospital admission policy during the pandemic. Evaluation for possible hypercoagulable states, cardioembolic sources, etc., should be similar to those without SARS-CoV-2. There is no need for routine screening for antiphospholipid antibody, for example. Management of acute stroke generally follows the usual standards of stroke care, including thrombolytic therapy, mechanical thrombectomy. There's no specific safety issues thus far. ACE inhibitors and angiotensin receptor blockers can be safely continued. Other cerebrovascular manifestations include cerebrovenous thrombosis, or CVT. This is associated with COVID-19, but also COVID-19 vaccines. And this is one example of it, of a patient who has infiltrates, consolidated areas, ground glass, head CT without contrast, and a CVT involving the superior sagittal sinus, including on the venogram. This is a retrospective multi-center cohort from 6 tertiary centers in New York City. This involved 13,500 consecutive patients. 12 had cerebrovenous thrombosis, much higher than in the general population, 8.8 per 10,000 in 3 months, versus 1 in 5 million in 1 year in the general population. Most of these patients in this series in New York were male. Average age was 49 years. The neurological symptoms were within 24 hours of respiratory symptoms in the majority of patients. Headache was in 85%, seizures and hemiparesis in 42%, and cortical signs were present really in only 25%, including aphasia, neglect, and hemianopia. 75% of the series had a venous infarction, hemorrhage, or both on imaging. Vessel imaging showed dural venous thrombosis in 83%, some with multiple dural sinuses involved, and isolated cortical vein thrombosis in 16%. Management in this series included anticoagulation in most. The remainder either died or refused anticoagulation, endovascular thrombolysis, and surgical hematoma evacuation in a few. Mortality was high, 25%. Here are some possible mechanisms of CVT and COVID-19. Cerebral venous thrombosis could be from vascular endothelial dysfunction, a prothrombotic or hypercoagulable state, as we had discussed, ACE2 receptors, platelet dysfunction, complement activation, cytokine storm, hypoxia, and antiphospholipid antibodies, as well as altered vascular flow dynamics. COVID-19 increases the odds of CVT by more than 40-fold, 1 to 5,000 to 15,000 patients hospitalized with COVID-19. More than 2/3 of patients with CVT associated with COVID-19 lack traditional risk factors for venous clots. The mortality is greater in CVT associated with COVID-19 than without. Then this came up in April of this year. These were cases of cerebral venous sinus thrombosis with thrombocytopenia after receipt of the Johnson & Johnson COVID-19 vaccine. This was an official CDC health alert in April of 2021. At this time, as of April 13, 2021, about 6.85 million doses of the Johnson & Johnson COVID-19 vaccine, Janssen, have been administered in the U.S. There were 6 cases of CVT reported to the Centers for Disease Control and the Food and Drug Administration, all with thrombocytopenia. And here, this made the lay press. FDA warns a potential rare neurologic complication with the Johnson & Johnson coronavirus vaccine. Just as a summary of the COVID-19 vaccines currently in use as of October 1, 2021, there's the Pfizer, Moderna, Oxford, AstraZeneca, Johnson & Johnson, and Gamaleya, and others. The ones I wanted to call attention to were the ones which are adenovirus vectors, which were these two, because in addition to the Johnson & Johnson, the CVT was associated with the AstraZeneca vaccine as well. Both adenovirus products. The vector mRNA vaccines were not associated with this. There is a syndrome called vaccine-induced thrombotic thrombocytopenia that came from all this, or VITT. This is considered a very rare complication of the AstraZeneca and Johnson & Johnson adenovirus vector vaccines. It's about 1 in 40,000 vaccinations for the AstraZeneca and 1 in 470,000 for the J&J. Characteristically, there's thromboses in the cerebral veins, which is the most common, but also the splanchnic veins. Within 28 days, the vaccine-associated CVTs can be seen with or without this vaccine-induced thrombotic thrombocytopenia. Generally, this is defined as any decrease in platelets less than 150,000 per microliter, and it occurs 5 to 30 days post-vaccine. In most series, there's a female predominance and usually young. The mechanism is thought to be DNA from the adenovirus vectors binding anti-platelet factor 4, anti-PF4, leading to autoantibody production. And it may look something like this. This is the mechanism of PF4 immune-mediated thrombotic thrombocytopenia associated with heparin. So the platelets here release platelet factor 4, binds to heparin in some patients. There's a charge stabilized PF4 and heparin complex. IgG binds to this PF4 heparin complex. And then there is other autoantibodies that processes that are involved, and this leads to platelet aggregation and clot formation. And in this instance, there's the autoantibody formation rather than the heparin is theorized to lead to platelet aggregation, which then leads to thrombocytopenia and clot formation. Again, perhaps similar in mechanism to heparin-induced thrombotic thrombocytopenia. This is a fairly typical case of a patient with vaccine-induced thrombotic thrombocytopenia associated CVT. This is from a United Kingdom cohort. This was a 50-year-old man who had received the AstraZeneca vaccine 17 days prior to these images. He presented with headache, confusion, and abdominal pain. This shows a venous infarct in the left temporal lobe, which was hemorrhagic. Here is a flow void left by the thrombus in the left transverse sinus in 2 different image levels. Also, flow voids from the left sigmoid sinus, the left internal jugular vein, and you can see the opacity here and here on the opposite side, and a pulmonary embolism as well. But it should be mentioned that the benefit of the adenoviral vaccines far outweighs any risks. And here is the cerebral venous thrombosis incidence in cases per million per year. On this axis, this is in the general population, so about 3 or so cases per million per year. And this is with COVID-19 itself in unvaccinated patients. And these are the risks in post-vaccination for the two different adenovirus vectors. So clearly much lower than the risk in COVID-19 itself. Another manifestation of cerebrovascular disease is intracerebral hemorrhage, or ICH. Early on, there were a single center series of ICU patients hospitalized with COVID-19, where this was described mainly in Wuhan and then in New York City. These are classified as being primary ICH with or without traditional risk factors, such as hypertension, and anticoagulation is included in that. And secondary ICH, meaning hemorrhagic transformation of stroke, CVT, or after an endovascular procedure. This is your typical patient with an intracerebral hemorrhage from COVID-19. It's a male who's 65 years old, multiple pre-existing risk factors, diagnosed with COVID-19 prior to the ICH. Patient started on anticoagulation in hospital prior to the ICH using unfractionated heparin. Presentation with severe headaches, impaired levels of consciousness, possibly hemiparesis, and a primary ICH is most common, i.e. not a hemorrhagic transformation of a stroke, and a single compartment intraparenchymal hemorrhage, and on mechanical ventilation in the ICU. I'd like to take a minute and discuss some frequently asked questions. I have a patient with severe COVID-19 pneumonia who has been intubated in the ICU for the past week. He was in cytokine storm initially, but improved after remdesivir, dexamethasone, and tocilizumab, an IL-6 inhibitor. His respiratory status is improved, and sedation was discontinued. His eyes are closed, he moves all his extremities, and has no focal neurologic signs. However, he does not follow any commands. His brain CT scan is negative. My question is, should we do an MRI to look for a stroke? Answer. Encephalopathy is one of the most common neurologic manifestations of COVID-19. This can be particularly severe and prolonged in those in cytokine storm, as in this case. The incidence of acute ischemic stroke in hospitalized patients with COVID-19 is generally low, around 0.4 to 2.7%. With critically ill patients, though, the incidence can be up to 6%. With a negative CT and a non-focal examination, it's likely that the yield of the MRI for an acute stroke is low, but cannot rule this out entirely. However, there are other diseases that may be missed on CT, including the cerebral venous thrombosis, parainfectious demyelinating disorders, and several others. An MRI scan is reasonable with the understanding that the yield is somewhat low. Next question. For the same patient, should we do a lumbar puncture to check for SARS-CoV-2 by PCR? Answer. Lumbar puncture is generally a low yield in the evaluation of encephalopathy in COVID-19. SARS-CoV-2 has been detected in cerebrospinal fluid by PCR, but only in a handful of cases. A positive PCR is unlikely to change the immediate management. Co-infections of the central nervous systems have been reported in COVID-19, but are extremely unusual. Rare cases of meningitis have been reported concurrently with the diagnosis of COVID-19, including from Cryptococcus neoformans and Neisseria meningitidis and a few others. These co-infections really are at a case report level and are unlikely to be present without some other clues such as meningeal signs, purpuric rash, an underlying immunocompromised disorder, etc. My patient is admitted with Guillain-Barré syndrome. She tested positive for SARS-CoV-2 on admission. She was not vaccinated. She is afebrile and has no pulmonary symptoms. Is the Guillain-Barré syndrome caused by the virus, or is it coincidental? A causal association between SARS-CoV-2 and Guillain-Barré syndrome remains uncertain. Several cohort studies have failed to show an increased risk of GBS. In one large cohort study from Great Britain, the incidence of GBS from March to May of 2020 actually decreased compared to the previous 4 years. Now, for an individual patient, causality may be even more difficult to establish. The clinical presentation of Guillain-Barré syndrome, quote, associated, unquote, with COVID-19 is similar to GBS cases without COVID-19. Miller-Fisher syndrome has been described. The cerebral spinal fluid findings are also very similar. To date, SARS-CoV-2 has not been detected in CSF by PCR in patients with Guillain-Barré syndrome. Most cases have been the axonal variant of Guillain-Barré syndrome or demyelinating. There is no contraindication to intravenous immunoglobulin or plasma exchange in patients with COVID-19. I have a patient with acute disseminated encephalomyelitis, ADEM, which we believe is from COVID-19. She's hospitalized on a regular nursing floor, and respiratory-wise, she's stable on 3 liters of oxygen by nasal cannula. Can we give pulse steroids for the ADEM? Corticosteroids are beneficial in certain hospitalized patients with COVID-19. Corticosteroids do not benefit those who do not require supplemental oxygen, but are recommended to treat the pulmonary disease in this case, usually in combination with remdesivir. There is no specific data on safety of pulse steroids in COVID-19, but there is no harm signal that has emerged as yet. There is a theoretic risk of increasing viral replication and prolonging viral shedding with steroids, depending on the timing of the steroids. However, in most instances, diseases such as ADEM should be treated in the usual manner, including corticosteroids at appropriate doses. Thank you very much for your time and attention today. Please feel free to email me with any questions. This is a rapidly changing field. Again, many thanks and best of luck.
Our next speaker is Dr. David Van Wyck. Dr. Van Wyck completed his medical degree in 2009 from Kirksville College of Osteopathic Medicine. From there, he completed his neurology residency in 2013 from Madigan Army Medical Center. He then completed his neurocritical care fellowship in 2017 from Duke University. Today, Dr. Van Wyck serves as a consulting associate for Duke University Department of Neurology in the neurocritical care program. He is also an assistant professor in neurology for the Uniformed Services, University of Health Sciences in Bethesda, Maryland. Dr. Van Wyck is a highly decorated lieutenant colonel in the U.S. Army as well. Thank you for your service, Dr. Wyck, and thank you for providing a lecture on prognosis after severe traumatic brain injury.
Hi, everybody. My name is David Van Wyck. I'm a neurologist from North Carolina with additional training and certification in neurocritical care and brain injury medicine. It is an honor and a privilege to be invited to speak at Ascension St. John's Stroke and Neurocritical Care Symposium for 2021. I'm really fortunate that it is a virtual symposium. So an instance where COVID actually worked to my benefit because I'm a military physician and I'm deployed to East Africa at the moment. So I'm taking a break from what they normally have me do in order to talk to you about prognosis after severe traumatic brain injury. So without further ado, I'll go ahead and pull up the slides and share my screen. All right, and let's talk about prognosis after severe traumatic brain injury. My first slide is actually the template gave me an opportunity to insert a quote, and I love this quote from Sir William Osler. I love all of his quotes, but I thought this one was particularly pertinent to the topic today because half, if not more, of what we're going to talk about is going to change in the future, and people that are much smarter than I am will be able to better inform you down the road a little ways how to get a good prognosis in severe traumatic brain injury. Because as you'll see, even with the tools that we're going to talk about, that's still very difficult to do. So The other element to this slide is a little bit about me and what I do. And I've listed a number of the different titles and the hats that I wear here. And when I was listing this out, it actually felt a lot like that scene in Rocky where Rocky's in the ring waiting for Apollo to come in to start their fight. And he's got something ridiculous like 10 or 12 nicknames that they announce him with. And I'm putting all this in there and thinking, I sound probably like that. And I do all these things and it might look impressive, maybe. But I assure you, I'm really not that important. I'm a humble neurologist who is just very fortunate to be able to take care of soldiers and their families. Likewise, I'm very fortunate to be able to continue working at Duke University Hospital, where I did my fellowship as a consulting associate. The Army said that was okay. Duke was willing to keep me around. So that's a great place to continue getting experience in training in neurology and neurocritical care. So because I'm a government employee, I have to tell you that what I'm going to talk about does not reflect the views and opinions of the U.S. government or these other organizations that I've listed in the paragraph. They're mine and mine alone. And other than that, I have no actual or potential conflict of interest in relation to this program or presentation. Brief outline, we'll talk a little bit about the importance of prognosis from the big picture, prognosis in medicine. We'll do a quick TBI overview focusing on mechanisms and pathophysiology to set the stage for the last part of the talk, which is prognosis in traumatic brain injury. So let's start with the importance of prognosis by giving us a situation or two that we can think about this question. And that question is, what do you tell this patient's family? So let's consider this patient. This is a real patient, by the way, that I encountered in fellowship. And it was a 31-year-old female with a 9mm gunshot wound to the head sustained during a home invasion. 2-centimeter entry wound in the right frontal temporal region. There's brain tissue protruding from that entry wound. There is a clinical exam that is notable for non-responsiveness, sluggishly reactive pupils. They're about 5 millimeters bilaterally. GCS was reported to be, or Glasgow Coma Scale score was reported to be 6 at the scene and 3T in the emergency department. And the CT scan is on the right, or a couple of images from it at least. And there's a lot going on in this CT scan, isn't there? There's an entry wound in the right frontotemporal region, so a compromised skull. There's metallic and bony fragments in different parts of the parenchyma. You have blood products of various types. You have intraparenchymal hemorrhage, intraventricular hemorrhage. There's a little bit of a subdural hemorrhage down here in D that you can appreciate. There's some subarachnoid blood in a couple of different images as well. There's midline shift, compression of the ventricles. So a lot going on here and a lot to consider when we are trying to form a prognosis for this patient to inform the family, who's probably going to be in short order, asking, is their loved one going to survive and how will they do? Let's look at another case and consider it from another point of view. This one is a 24-year-old female who's an MBA, and she crossed into oncoming traffic and was hit by a semi going about 70 miles an hour. GCS on arrival was a 3. And interestingly enough, the ED was noting rhythmic facial contractions confined to the face, so nothing in the body. The CT head over here shows some concerning findings as well. There's loss of gray-white junction. You don't see any of the sulci. You don't see any of the deep gray matter structures like the thalamus, the internal capsule, the caudate. And normally in a healthy brain, you can see those, but you don't here. So that's indicative of diffuse cerebral edema. So that in and of itself is a concern. But sometimes we also have to look at other evaluations that have been done by our colleagues in the ED or elsewhere to help inform us and to give us an idea how well the brain might do with these other injuries. For example, this patient had a CT C-spine that showed an atlantoaxial dislocation. And if you go through the literature that talks about AA dislocations, they're often pretty severe. 60 to 80% of the time, depending on what you're reading, there's a poor outcome associated with that finding alone, usually paralysis, but sometimes death. And the key here is that spinal cord injury co-occurs with brain injury relatively frequently, depending on the source that you're evaluating, anywhere between 25 to 60% of the time. Probably most often with motor vehicle crashes, but also with falls and other types of TBI as well. And in this case, the patient's rhythmic facial contractions was because the AA dislocation had essentially caused an internal decapitation. So that patient's spinal cord connectivity was severed from the rest of the nervous system as a result of this injury. But the question remains the same. When somebody shows up and wants to know if this patient is going to survive, and if the answer is yes, how they're going to do in the long term, you have to be able to give them some type of indication as to what they're looking for. Prognosis in medicine goes all the way back to ancient Greek times, and the word prognosis actually comes from Greek, which from a word that means to foretell or foresee. And in this quote from Hippocrates, you can really see that the value of an accurate prognostication was valued not only by the patient, who wanted to know what their disease course was going to look like once they were diagnosed, but also by the medical practitioner, because if you could accurately diagnose somebody and then tell them what the disease course was going to look like, well, that enhanced your credibility and reputation, and that brought good things to you. So again, even in ancient Greek times, the importance of this was appreciated. All right. So why is this the most important thing we do, or one of the most important things we do? Well, prognosis, more than anything else, certainly more than diagnosis, is the most essential element for treatment decisions in neurocritical care, and really in all or most of medicine, because it's the foundation for medical intervention. A lot of the decisions you're going to make are going to depend on how well you think that patient is going to do. If you think they're going to survive, the next question you're going to ask is, do you think that they're going to have any kind of quality of life? And if the answer is yes, then you're going to go down one treatment pathway. If the answer to those questions is no, you may go down a completely different pathway. So as a provider, this provides a lot of useful information to you as to what you're going to do next. For the family, it's also valuable. When you talk to a family, take those two vignettes, for example. When you talk to a family about what your findings are, they don't really care. I don't think that they really care about all of the details of that CT scan that we talked about, for example. What they're really looking for when you're telling them all that is, how well do you think that patient's going to do? Do you think they're going to survive? And if you think yes, what's their functional outcome going to look like? And there's a couple of different elements of functional outcome listed on this slide here. The question is going to be, are they going to be independent, semi-independent, completely dependent on care? They're going to be able to return to work? Those are the sorts of questions that family members, loved ones really have. So this is critical information for both providers, but also for patients at some point, hopefully, and their families. And when we're formulating a prognosis after TBI, we're thinking about the expected duration of the condition. We're talking about the level of function that we think the patient is going to have during the recovery course and at the end of the recovery course, the description of the illness, injury, and recovery course. And then it's important to talk about potential complications or what can go wrong, because once you give a family or a patient an inclination that there is hope in that recovery course, a lot of them will cling to that. But it's important to recognize that there's a lot that can go wrong in the ICU. It's that acute and subacute period, but even in the rehab period, there's a lot that can go wrong that'll set that patient back or potentially have some type of permanent deficit associated with it. So patients need to know that, and they want to know that. So this is all important information to consider. And some of this is not going to be information that you're going to be able to provide right away. This takes time. And especially when you're talking about those functional outcomes, that's something that you really have to wait on a little bit to see how patients do. That's a tough question to answer acutely. So how valuable is accurate prognostic information? Well, according to this study published in 2007, looking at the responses from 60 physicians, it's pretty darn important. And if you look at the first three in this list, the ability to have accurate prognostic information was very important to the vast majority of physicians surveyed as to whether or not they would send a patient for a decompressive craniectomy or to the ICU, or even for medical interventions for high ICP or for TBI. So this reiterates the importance of having prognostic information to inform our treatment decisions and the pathway that we're going to go with the patient. One of the most valuable things I learned in my critical care fellowship was during palliative care, when one of the attendings said that in critical care medicine, there's a lot that you can do to a patient, but what you really have to ask yourself is what you can do for the patient. And this is where prognosis comes in, and the ability to generate an accurate prognosis. How do we think we do? Well, those same 60 physicians were asked that same question. How well do you think you can prognosticate after a TBI. And most of them were intensivists and or neurosurgeons, but 37% of those surveyed, it was a small number granted, but 37% of them said that they could prognose a patient accurately after TBI. That's not a lot. That's most of the patients, about two-thirds of the physicians saying that they would question the prognosis that they generate after severe TBI. Likewise, 67% thought that a more accurate prognostic model would change their practice. And fortunately, this study was published in 2007. So about a year later, the impact database had been completed and that information analyzed. So they published a lot of information on TBI in 2008, including the impact score. So they kind of got their wish in one sense, if they were looking for a model that would help them. But the point is that we question our ability to do this in TBI because it's very difficult and there's a lot of factors to consider. Why is using personal experience not a great idea when trying to formulate a prognosis in TBI? Well, personal experience, and it's only human to do this, but personal experience can be subjected to a lot of different types of biases or cognitive distortions, self-fulfilling prophecies, influence from skewed examples in the history. The bottom line is that subjective estimations are shown to be far less accurate than validated methods. That's not to say that validated methods are 100%. They definitely have flaws too. And we'll talk about the impact score here in a little bit. But they are generally better, have been shown to be better providing accurate prognosis than trying to do it from personal experience because of those biases and distortions. And here's an example of that. So this was two clinicians and some nurses who were asked on a daily basis to assess their TBI patient and come up with a decision or prognosis as to whether the patient would die or whether they weren't sure what the outcome would be on a daily basis. And that was up against computerized trends of daily Apache 2 scores. And in the end, the docs and the nurses had a false positive diagnosis rate for dying of between 8 to 17% roughly, whereas the computer had a false positive diagnosis rate of 0. So why was that? In theory, it was because some of those personal experiences were injected into these situations, and it skewed the diagnostic accuracy to some degree for the docs and the physicians, whereas the computer was not restrained by those types of biases and distortions. So once again, as best you can, try to use the validated methods and the evidence-based methods to help you when you're formulating prognosis in TBI. Next, we'll talk about severe TBI mechanisms and pathophysiology. And again, this will be a relatively simplified and shortened overview, but I think that it sets the stage for the discussion in the third section about the prognosis after TBI and how we do that and why. So head impacts in TBI is really a potential energy or from an external force or an external force that has a potential energy and then converts that into a kinetic energy. And that's regardless of whether we're talking about a fall or blunt injury, a blast or a penetrating injury. So that potential energy becomes a kinetic energy. And once it impacts the skull, it is converted into a deformation energy. And that deformation energy is what damages the skull and the underlying brain tissue. And that's where brain damage or brain tissue injury comes from when that external force is transferring that energy to the skull. And there's different tissue stress thresholds for injury. They can be impacted by the duration of the force. There's thresholds for injury for different types of forces as well. But this is essentially what's happening when we're talking about a TBI, an external force being imparted on the head, resulting in brain injury. And as the head is impacted, the brain keeps moving. It's coupled to the skull by cerebral spinal fluid, and it moves around. And the result in a lot of these injuries is that the brain will crash into the skull, displacing some of that fluid, and it hits up against the skull. So brain tissue is injured by both compression and by shear. And although the skull is designed to protect the brain, and certainly, if you fracture the skull with a given force, there is a much higher likelihood that the underlying brain is going to be injured as well. So that's something to take into consideration. But it is not necessary for a skull fracture to be present in order for a patient to have underlying brain injury. That's probably not a surprise to most people who have seen a mild traumatic brain injury, for example, where a skull fracture is very uncommon. But it's important to recognize, even in some of the more severe injuries, that a lot can happen to the brain in the absence of a skull fracture. In terms of mechanisms, there's 3, possibly 4, with blunt and closed being the most commonly encountered. So falls, MBAs, assaults, and certainly the best studied of the group. Penetrating would be some type of projectile or a missile that strikes the head. It can be divided into low velocity and high velocity subcategories. You'll see these as well. Gunshot wounds to the head, primarily from handguns into the civilian settings. Rifles and higher velocity weapons are going to be more in the military setting. Blast is the third one, and that is definitely more in the military setting, and that's been the focus of a lot of research in the past couple of years because of its prevalence in the war on terror. And then lastly, you have direct energy, which is what's been referred to in the media recently as Havana syndrome, or anomalous health incidents is the new term. And the theory there is that radio frequency waves or high-powered microwaves or potentially sonic waves are, when directed at certain frequencies and power levels, are able to cause brain injury. So that's controversial. There's not a lot of patients that have been described as having been subjected to direct energy and potentially having a brain injury, but it's something that there are increasing numbers that we're seeing. So this is something I think that will develop in some form or fashion in the future. So we'll see where that goes. Again, closed and blunt injury, well studied. It's essentially a mismatch in brain and skull movement. The bat hits this patient, so there's an impact site in the frontal area there that causes the head and the skull to move, and likewise the brain moves within the intracranial vault and smacks the back of the skull or the back of the head. So that's that kind of classic contra coup injury, and oftentimes the contra coup injury is the more severe injury. But there's but this is the most common type of TBI, and like I say, mechanisms include falls and MPAs and assaults. Then you have penetrating, and there's low velocity subtypes, which like this patient here, this was a psych patient at Duke who got a hold of an object that he was not supposed to have access to, in this case, a pen, and he shoved it into his eye socket and shoved it far enough that it actually went into brain tissue, as you can see in the image on the right there, or in the middle rather. And he managed to put this on a trajectory or a vector where he missed all of the critical structures that he could have potentially hit. A slight change in that would have in that trajectory would have changed things significantly for him, but managed to get that pin in pretty deep. But there's generally a better prognosis with low velocity penetrating injury compared to high velocity, at least. The object is often protruding. That's the case here, although there's usually more of it protruding. And if that's the case, the idea is to stabilize it. Don't try to take it out, because trying to remove it or manipulate it can cause worse injury. Leave that to our surgical colleagues in the OR. They'll take care of that. Just stabilize it in place as best you can if you encounter a patient like this. And it's important to also make sure that you rule out associated cerebral vascular injury and pseudoaneurysms. They're pretty common, especially if the trajectory of the object is pretty close to blood vessels. High velocity injuries are a different story. The basis of this is the high degree of kinetic energy, which is generated by the high velocity of these projectiles. So kinetic energy is 1/2 the mass times the velocity squared. So what that means is that a larger object is going to do more damage, but a fast object is going to do even more damage than that. And that's why these military style rifles and hunting rifles do so much damage, is because the muzzle velocities of the projectile are so high, thousands, 2,000, 3,000 feet per second, for example. So the kinetic energy that is generated from that is transferred to the head and the underlying brain. Another factor is the angle of yaw, or how the bullet rotates along its original axis. So it basically turns, and in doing so, it presents more surface area to the tissue, so it creates a larger wound tract as a result. You also have projectile characteristics. Full metal jackets, for example, tend to cruise right through tissue, whereas soft points and hollow points tend to expand and mushroom out, and they create much larger wound tracts and do more damage. And then the other factor to consider is the tissue characteristics, such as the density, the strength, and the elasticity of the injured tissue. Brain, for example, is very dense and not very elastic. So that means, like the liver, for example, another organ with similar characteristics. And that means that when a projectile hits that tissue or traverses it, more of its kinetic energy is dissipated into that tissue, so more damage is done. Conversely, a low density and highly elastic tissue like the lungs tends to tolerate something like a gunshot wound a lot better than the brain or the liver, for example. Blast is really interesting, and there's a lot of data on this now and a lot of publications on how the pathophysiology is different. And it is really interesting. So you look at the pressure gradients and how they affect the skull and the underlying tissue in blast injury versus classic blunt injury, as illustrated in the graphics that I provided. And there's a couple bullet points that are mentioned there too that talk about the differences between impact versus blast injury. So really interesting. It's beyond the scope of the talk today, but if you're interested, just go to PubMed or Ovid or any of your favorite search engines, and you can find a lot of information on this. And it's often associated with polytrauma. It's uncommon in the civilian setting, but it's not totally impossible to see. So this was a picture I took from the 8th floor of the Duke Medical Pavilion in April 2019. And this was after there was an explosion downtown because of a gas leak, and it resulted in a mass cal. And this was one of the patients that we received. And as you can see from the CT scan, there is a lot of small hyperdensities in the superficial tissue and the muscle of the face, head and neck area, and that's all shrapnel from the blast that ended up in this patient. So if you continued to scroll upward, you would see this at higher levels as well, including penetrating TBI from that shrapnel. So this gentleman underwent a hemicranie and had a lot of pretty extensive burns as well. So he ended up in our unit along with a couple of other patients for post-op care. Talking about blast, there's a couple of different injury patterns and mechanisms. The primary blast mechanism or injury is from the blast wave itself, so that overpressure that is generated from the explosion. That tends to cause mostly hollow organ injury, so tympanic membrane ruptures, for example, are pretty common as a result of primary blast injury. Secondary blast injury is what we just saw in the last patient in those images that I showed you from that patient, and that's the shrapnel or the debris that is thrown from the blast that then ends up impacting or embedding itself into the patient. Tertiary blast injury is the injury that occurs as a result of the individual being thrown from the blast wave and then striking a surface like the ground or a wall or whatever else may be in the area. And that can certainly include the head, which can be injured in that phase or that by that mechanism as well. And then quaternary injury is the result of just about everything else. So the thermal effects of the blast, the chemical effects of the blast, all that has the potential to create injury as well. And that falls under that quaternary mechanism or quaternary injury pattern. And then lastly, direct energy. So again, poorly understood and controversial, but very interesting from an academic standpoint. This paper actually was hypothesizing a mechanism where, because the brain is about 73% water, direct energy such as microwaves can excite brain water phonons or heat particles. And as they heat up and they vibrate or oscillate, they create pressures that can damage tissue and create some of the unique acoustic effects that have been attributed to microwaves and radio frequency waves. So again, not a lot of patients for this. There's still a lot of questions regarding this mechanism and how it affects the brain potentially, but it will be something I'm sure that comes up again and again in the future. So we'll know more about it as time goes on. In TBI, there are two phases of injury. There's the primary phase, which is immediate and untreatable. And the best way to affect primary injury is to prevent it and avoid it altogether. It can be very severe and it can result in death. So these are patients that die very quickly. The high velocity Bullet wounds, for example, oftentimes cause very, very severe primary injury that is incompatible with life. But for those who survive, what we're really looking at doing is addressing the secondary injury. And there are many mechanisms, as you'll see in a moment, that can arise in delayed fashion, minutes, days, even weeks later. But a lot of these are amenable to treatment. And this is what we're focusing on and targeting in order to prevent that patient from dying and to maximize the potential for them to have a recovery of some sort, hopefully a good one, as time goes on. This is these are two of my favorite pictures, classic pictures and graphs for neurology and discussions about ICP or cerebral edema being one of the mechanisms that can worsen over time and cause worsened brain injury. So this graphic on the left is essentially showing you the Monroe-Kelly doctrine. And if you've never heard of the Monroe-Kelly doctrine before, that essentially is telling us or describes the head and the skull as a box, and it has that box has a fixed volume, and that volume is divided up into three compartments: brain, blood, and CSF, and that those volumes are in fixed amounts. So that basically means that you can't really add anything to the brain without decreasing something else. So an increase in one compartment requires a compensatory decrease in one or both of the other compartments in order to maintain normal pressure. And that's what that top box is showing us. When everything is in its steady state, there's a normal ICP. But when it's not, and a new mass is introduced, like a tumor or a bleed or edema, there is a compensated state that is able to keep the ICP in a normal range. And the reason that happens is because as that mass is presenting itself, blood is moved out of the intracranial vault or shunted out of the head, and CSF is shunted into the spinal canal. So we're decreasing the volume in those other compartments, like I talked about before, in order to accommodate this new volume. And that's great, but you can only move so much CSF out or only move so much blood out. And if that mass continues to expand, something else has to give, and that's usually the brain tissue itself. So brain starts getting compressed or moving in places where it's really not supposed to go. We talked about the cranial vault as being a rigid structure, and it's not completely. There are openings in it, as you well know, and sometimes brain moves through that. So this is where things really start to go bad, and that's what this graphic on the right side of the screen is showing us, and that's the volume pressure curve. So that blue part of the line there is that top box really, and that's where compliance is high. And ICP is normal, or at least compensated. And as we start to move into the yellow phase, we see an increasing volume, but pressure stays more or less the same, or within a confined range, at least, as those compensatory mechanisms that we discussed help balance that. But you usually hit a point where there is no more compensation available, and compliance is decreased significantly. And then all of a sudden, with just a little bit of an increase in volume, there is a drastic increase in pressure. And that's that dangerous part, that box at the bottom. That's this part of the line right here. So that's what we're trying to avoid. We don't have great data on whether waiting to treat high ICP is better than trying to prevent it altogether aggressively. So that's a question that still really needs to be answered in neurocritical care. But this shows us a little bit about what's going on in the brain with traumatic brain injury and swelling, and how it can affect pressure inside the cranium. You might say, I've heard before that treating ICP doesn't really improve outcomes, and you're not wrong. We've not really shown that controlling ICP always results in a good outcome, but we do know that not controlling ICP results in bad outcomes, namely death. So this particular paper in this graph was depicting the results from their study, which had shown that and once you get above 20 millimeters of mercury, the mortality rate starts to increase significantly. So 30 and 40, much higher mortality rates than at 20 or close to 20. And then when you get into 50 or higher, it was almost 100% mortality, or frankly, in this graph, it was 100% mortality. So the brain does not accommodate acute increases in volume and pressure very well, and that can be deadly to a patient with TBI. And this is meant to display the myriad of secondary injury mechanisms which can occur following TBI, anywhere from a couple of seconds after the injury minutes, hours, and even days to weeks later. So this is why patients are so labor and personnel intensive, is because there's a lot that can go wrong, and there's a lot of things that we need to intervene on and watch for in these patients in order to keep them alive and to maximize their potential for recovery. So the last slide for this section is on treatment considerations. And again, this is a discussion for another day, for another lecture. But these are some of the mechanisms by which we would control secondary injury and try to prevent progression of brain injury. And hemodynamic control and airway and oxygenation are at the top of that list. We'll come back to that in a few slides. Certainly ICP and CPP, or cerebral perfusion pressure management, are important. Seizure management, antibiotics when indicated, glycemic control, temperature management. These are all factors that need to be considered and potentially addressed in order to keep these severe TBI patients alive and to give them the best chance for a good recovery. So with that background and that discussion completed, we'll move on to prognosis after brain injury. And just like I started the lecture, I want to give us a vignette to sort of think about as we're talking about these. And there's no right or wrong answer to this. Just think about some of what we talk about and what you might provide as feedback or information to this medic that's asking for help with regard to this patient that he has. By the way, that's a picture of me in Afghanistan. That's the Helmand River back there. It is actually a really pretty place. There's some amazing sunrises when I was over there. So great memories. But this is based off of a real life scenario that I had encountered, and you are essentially woken by an early morning or late night phone call by a special operations medic who is participating in an advise, accompany, and assist mission for a partner force unit. And while they're out moving around, they're struck by an improvised explosive device. So we get a blast mechanism of injury, and there's a couple of killed in action. There's a couple of wounded in action. And one of the wounded in action appears to have a head injury. And the thought is that some type of object or shrapnel struck this individual in the head. They're in their 40s somewhere, and a male. On scene GCS is a 4T. The medic already did a cricothyroidotomy, which is pretty common for soft medics to do. That's how they secure airways. And pupils are sluggish bilaterally. There's a large frontal scalp hematoma and bleeding. It doesn't look like anything penetrated per se, but there is some deformity to the bone in that area, so likely a fracture of some sort. There's no other obvious signs of serious injury. One of the partner force medics that got to the patient first gave some morphine, but no other medications were given. So that's important because that may potentially affect vitals like blood pressure. It may affect respiratory drive, and it may affect sensorium too. So that could be something that's causing the GCS to be where it is, or severe brain injury. And here's the vitals for this patient. The patient is currently being bagged as well while they're setting up a ventilator. And the soft medic is asking for some guidance. And what they're really asking is for recommendations and prognosis a lot of times, because they want to know if the patient is potentially salvageable. These folks have limited trauma supplies, medications. They carry a couple of analgesics and sedatives. They do have hypertonic saline available. But all this is being carried in an aid bag, in a backpack, more or less. So they don't have a lot to go around. And they know that head injuries, oftentimes, especially the serious ones, are labor intensive and personnel intensive. So if the patient is salvageable, then they're willing to put in the work. But they're also asking the question, is it worthwhile to dump what limited supplies I have into trying to care for this patient if there's really no likelihood that they're going to survive the injury to begin with? So what information do we have? What information do we need in order to help make a prognosis for this medic so he knows whether to start aggressively treating this patient or save his supplies for potentially another casualty that they may encounter as the mission continues? Again, just factors to consider. This is a graphic from Jack Jallo's Neurotrauma, second edition text from 2018, connecting prognosis to these different types of functional outcomes. In our medics situation, I think what they are really asking is this patient going to survive? And these are questions that they would address later regarding functional, cognitive, behavioral, and physical outcomes. But all things to consider in a TBI patient, and certainly things that family and loved ones are going to want to know, and frankly, that the providers are going to want to know at some point as well. And there's a lot of factors to consider in TBI prognosis. A lot of these don't have robust evidence for them, and a lot of them are not going to be elements that you're really going to seriously consider or talk about when you're giving a prognosis to a family. You're probably not going to talk much about socioeconomic status, for example. And genetics, while very interesting, is probably not information you're going to have. It's highly unlikely that a patient is going to know their ApoE4 status, for example. So we'll focus on some of the more common ones, like the imaging or the performance on clinical severity measures, to help us with our prognosis. But there's a lot, so be aware of that, and some of them are quite interesting. So the first thing we have to do is determine the severity of injury, and that can be determined from the Glasgow Coma score, from CT imaging, loss of consciousness if there was one and how long, alteration of consciousness, post-traumatic amnesia. But for our medic, most of these are not going to apply. They're not going to have CT imaging. They don't have the time to wait 24 hours or even longer to determine how loss of consciousness, AOC, or PTA are going to affect a patient. So really all they've got is the GCS score to help them with prognosis. And that's not a terrible thing, because as it turns out, the GCS score is one of the best, if not the best, in terms of evidence element of for prognosis in a severe TBI patient. In general, the lower the score, the poorer the outcome. And the motor score in particular, if you look at the results of the IMPACT database, has the greatest predictive value in patients with more severe injuries. That's not to say that the eye and the verbal components don't matter. They do, but the evidence for them were less robust, and it's probably more relevant in patients with less severe injuries, so those moderate and mild categories. I also want to mention briefly the Glasgow outcome score, which is different than the Glasgow coma score or scale. The GOS is what is used in most of the TBI prognosis studies to differentiate between good and bad outcomes. So you'll hear me in a couple of slides talk about good or better outcomes or worse or bad outcomes. And most of those studies are using this score at 6 months or 12 months to determine good versus bad outcomes. So a GOS of 1, 2, or 3 with the resulting interpretation over here on this side of the screen is associated with or is defined as a bad outcome or associated with poor outcome. Whereas a 4 or 5 in the resulting interpretation are considered good outcomes. So keep that in mind as we go through some of the slides that are coming up. Now, give this some thought. Which of the following on-scene GCS scores do you think is worse in terms of outcome? A GCS of 4 or GCS of 3? And there's a reason that I'm asking this question, and we'll talk about it here in a moment. But think about this, come up with your answer, and continue to think about it as we talk about GCS in this next slide. So GCS scores fluctuate early after injury. And it's important to know where in the timeline the GCS score you're being provided with was obtained, because the prognostic effects of the GCS are different depending on when the score is recorded. Was it an on-scene GCS? Was it at the time of admission? Was it following stabilization in the ED or elsewhere potentially? And the reason for that is looking at this graph that I put in from this 2007 study. They recorded the motor score. So again, the motor score being the most important element in severe TBI, at least. They recorded the motor score at the time that the patient first presented to the hospital. So that for most patients is going to be the ED. And subsequently the enrollment motor scores after the patient was treated, presumably in the ED. And what you see is going down the line is there are patients on either end. So the scores were different for some people from first admission to, or from first presentation to enrollment or at the time of admission. Even when you look at individuals who had no motor score, didn't do anything, there's a couple, not many, but there are some who improved by the time of their enrollment. And you see that across the board, and patients go both ways. So when we talk about GCS being useful for prognosis in TBI, but the question becomes, where is it most useful? And the answer to that is kind of across the board. There are some studies that say that the on-scene GCS is valuable in predicting outcomes at 6 months, for example. There are some that say at 6 hours. There's some that say at 24 hours, and some authors even think that longer than that is necessary. But most of us believe that the post-stabilization or the post-resuscitation GCS is considered best suited for predictive purposes. Why is that? Well, let's go back to the question I had on the prior slide. So what does a GCS of 3 mean? It means that the patient's not doing anything, motor, eyes, or verbal, right? So could that be from severe brain injury? Absolutely. But could there be other elements or factors involved that would affect neurologic function to such a degree that they may not have much of a clinical exam? And the answer to that is yes as well. So consider trauma. Could hypovolemia or blood loss affect cerebral function? Sure, if it's severe enough. What about acidosis? Absolutely. How about hypothermia? Or essentially the lethal triad, or it's a lethal diamond now with hypocalcemia. But could those elements that we just talked about affect cerebral function? Sure. Can you correct those? Absolutely. And if you do, does the exam improve? It certainly could. So contrast that with a GCS of 4. This was a conversation, by the way, that I'd had with one of our neurosurgeons at Duke, and he really presented this idea to me. And I thought, wow, I think this guy is right. But going back to what we were talking about with a GCS of 4, that tells me that there is some function. Usually with a GCS of 4, it means that there is extension. So the motor score is a 2. So that says that there is some brainstem function if you're extending, but nothing above that, potentially. Nothing above that seems to be working. So that tells me that there's probably severe injury, especially at the levels above the brainstem, and that it's less likely that some of those other factors that we just discussed are severe enough to influence neurologic function to completely eliminate that. So that's more worrisome to me than a GCS at 3, because a GCS at 3 tells me that, hey, I might be able to resuscitate this patient and get some of this exam back if these other factors are influencing the neuro exam. In any case, survival for those lower scores is fairly low, as indicated on the slide here. But interestingly enough, in this particular study, the higher scored severe categories actually had comparable survival to the moderate and mild severe TBIs at 83 and 84. And why is that? Because that's not always the case. In some of the older studies, the survival rates were much less. And one reason is because I think we've gotten better at treating this in the field and being aggressive with management of hypotension and hypoxia, for example. And a lot of places tend to be pretty aggressive with surgical management in these severe cases as well. So that may be influencing survival rates in some of these more recent studies. After GCS, the next most important factor to consider is age, and there's a number of studies that have identified this as well. So poor outcomes when you're really young. The patients under the age of 4 tend to have a high head to neck ratio, so that means that more of that force that is imparted on the head is transmitted to the brain. And then over the age of 65, and this is independent of other variables. So just the fact that you are older means that if you sustain a TBI, that means that the outcome is in all likelihood going to be worse. And you start to see worsened recovery after TBI beginning at the age of 40. And in some studies, it even starts after the age of 35. So both of these graphs over here from different studies show that the probability of survival decreases the older you get. So for those of us who are approaching our midlife or in our kind of middle ages like myself, if we are subjected to a TBI, our age itself is a factor that as we continue to age makes recovery and outcome much less likely, a good outcome much less likely. Length of coma is another factor to consider. Probably not going to help our medic from that vignette because it's going to take several weeks. But if you're in the ICU, this is certainly something to consider. And Douglas Katz and a couple of other folks have published numerous articles on this. And in general, good recovery is unlikely if the coma lasts longer than 4 weeks. Conversely, severe disability is unlikely if the coma lasts less than 2 weeks. So bad outcome or worse outcome for comas longer than 4 weeks, and better or good outcomes for comas that are less than 2 weeks. Post-traumatic amnesia. So another one, this one takes even longer to gauge, but now we're starting to move into not just determining whether the patient will survive, because by 2 or 3 months, you probably have a good idea about whether that's going to happen. Now we want to know more about the functional outcome. And this is one of those elements that might give us some information or some insight into how they will do in terms of behavior or cognitive status. So in general, the longer post-traumatic amnesia lasts, the worse the outcome. And post-traumatic amnesia is defined in most cases as ending when the Galveston Orientation and Amnesia Test score is greater than 75, or if the OLOG is greater than 24, if you use that test, for 2 consecutive days. And what Douglas Katz and others have found and published on is that good outcomes or good GOS scores are unlikely if amnesia is longer than 3 months. Conversely, severe disability is unlikely if amnesia lasts less than 2 months. So with that 2 to 3 month period being kind of a gray zone where it could potentially go either way. But this is something that as the patient moves into the rehabilitation phase, may be useful information in informing family members about cognitive outcomes, behavioral outcomes, for example. Not surprisingly, brainstem injury, when it occurs, is associated with worse outcomes. The brainstem itself is typically pretty well protected, so it takes a lot of force in order to injure that part of the brain. So when that happens, you're going to look for pupillary responses, oculovestibular reflex, oculocephalic reflex, and if those are impaired or absent, that typically portends a worse outcome. Pupil reactivity was something that was looked at in the impact database pretty significantly, and even if you had one non-reactive pupil, that was associated with a bad outcome. So you see that in this middle table here, where the odds ratio for a bad outcome was in the kind of 4 to 5 range in most cases, and if you had 2 unreactive pupils, that was associated with an even worse outcome or likelihood for a worse outcome. And you can see that over here in this far right table, where the odds ratio for a bad outcome is more in the kind of 7 to 9 range there. A couple studies have looked at the field GCS score and the admission pupillary reactivity as being good predictors of mortality at 6 months. But once again, post-stabilization pupil reactivity is probably the best predictor, and there's still quite a bit of good evidence for that. Most of us are going to use that post-stabilization exam as our indicator for how well a patient is going to do, and that includes pupil reactivity. Now, hypotension and hypoxia. Why is this important? And I mentioned this already on the treatment slide as to why these two were listed above ICP and CPP management. So this goes back to Randall Chestnut and some of the data that he published in the 90s, as well as a couple of others as well. And essentially, the blood pressure is tied to cerebral perfusion pressure, because cerebral perfusion pressure is the mean arterial pressure minus the ICP. So that means that we can maintain cerebral perfusion pressure if blood pressure is higher, if we push the blood pressure up or maintain blood pressure. And that oftentimes will actually have a greater effect on cerebral perfusion pressure than managing the ICP. In any case, what these studies had demonstrated was that a single systolic blood pressure, less than 90, from the time of injury to admission was associated with a 2-fold increase in death in TBI patients. Likewise, hypoxia, particularly a PaO2 of less than 60, which is usually going to be an oxygen saturation less than 60% in a lot of cases, is going to be associated with a 2-fold increase in death during that same period of time as well, from point of injury to admission. So if you combine the two, it gets even worse, and it's a 4-fold or higher increase risk of death. So this is why it's so important to maintain hemodynamic control and to manage hypoxia and oxygenation in your severe TBI patients. Imaging is another one that's been looked at fairly extensively. And in general, the number and extent of findings on your CT or MRI are going to correlate with recovery. So more findings indicative of worsened recovery, so a negative correlation. The CRASH collaborators, the CRASH study collaborators looked at specific findings and identified cistern, obliteration, and midline shift in particular as as negative prognostic findings, and a couple of others as well, like extensive traumatic subarachnoid hemorrhage, acute subdurals as well. And if you go to MRI to look at the brainstem, because you may not be able to see on a CT injury to the brainstem very easily, deep lesions on MRI in the brainstem, and particularly if they are bilateral, are associated with worse outcomes. So this particular image here is a GRE. So those dark areas, those hypointense areas, are showing us blood product deposition, and you see blood product in the bilateral midbrain. So we've got the imaging criteria that we just talked about to indicate a poor outcome, and the fact that the brainstem is injured. We just talked about that, another indicator to suggest a poor outcome in this individual. I'll talk briefly about the zona fatalis. This is a phenomenon that occurs with gunshot wounds to the head. And this was originally introduced by Kim and colleagues in 2005, who were doing a vector analysis of gunshot trajectories from gunshot wounds to the head. And what they found was that this area, approximately 4 centimeters above the sella, the dorsum sella, when a bullet traversed that area, it was associated with 100% fatality. And that makes sense because this is the location of important structures like the thalamus and the hypothalamus and the circle of Willis, all structures that, if injured by a projectile of some sort, probably are not going to do well, considering all the regulatory functions that those structures serve, or their importance in blood supply. So that's you can see in the graphic here that all of the ZF spots, those patients died. And likewise, when more lobes are involved, particularly 3 or 4 lobes, there is a higher rate of fatality as well. So these are gunshot wounds that are going to ricochet off the inner table of the skull and take a different trajectory, or potentially ones that fragment and go in different directions. That happens sometimes as well, can injure multiple lobes, and that increases the risk of a bad outcome, specifically death. Biomarkers are really interesting, and there's a lot of potential. There's a lot of interest in using these for prognosis and TBI, and they essentially offer a quantitative data point to measure the extent of injury. So the problem is that the results are inconsistent, and frankly, some of these can be elevated with trauma outside of the brain or with other conditions like myocardial infarction. That's the case with glial protein S100B. The other thing we don't know is whether or not combinations of some of these markers is better than other combinations or isolated marker results. So I think that this is something that will grow. There's certainly a lot of potential utility, like in the ICU. It might be a marker for secondary injury. It might help inform decisions about withdrawal of care, for example. But a lot of this is still in its infancy, really, and there'll be more that comes out on this in the future. Of the markers that have been studied, glial fibrillary acidic protein probably has the best evidence for prognosis in TBI, and this is a intermediate filament protein that is concentrated in astroglial cytoskeleton. So what's nice about that is that it is confined specifically to brain tissue, and it's not found in the peripheral circulation, but it's also not completely unique to traumatic brain injury either, because GFAP can be elevated after stroke or intracerebral hemorrhages as well. So, but the graphics over here on the left side of the screen are showing you that higher GFAP levels have been associated with unfavorable outcomes, whereas lower levels have been associated with favorable outcomes. And then the specific GFAP levels predicting unfavorable outcomes are in this table here after severe traumatic brain injury. So oftentimes, the higher the value, the worse the outcome. And then lastly, the impact score came from the impact database that was published in 2008. I put the URL or the link down there at the very bottom bullet, in case somebody would like to go and look at the calculator itself and input data for a patient that they have. The impact score provides a prediction for 6-month mortality and a likelihood of an unfavorable outcome after moderate to severe TBI. It's for patients that are older than 13. they have to have a GCS less than 13, and it's for data that is accumulated in the first 24 hours only. This was never meant or tested to be used for serial evaluation. So doing it a week later or a month later really is not useful. It's meant to be done during the first 24 hours of admission only. So the other potentially limitation is that it may not be quite as useful in austere resource limited environments because it asks for data from the CT scan and from labs as well, which individuals may not have, or a medic won't have that, for example. And it's also best used for isolated head injuries. So if you've got a polytrauma, you may have to use some other prediction scores to help you with prognosis. So this is best utilized if it's just head injury. And there's a couple different versions of it. There's the core version, like I was talking about. If you don't have lab and CT capability, there's a version with just CT, and then there's a version with just CT and lab. Regardless of which one you use, the trends are pretty consistent, with the higher score indicating a higher likelihood of unfavorable outcome and or higher mortality at 6 months post-injury. So in summary, what I hope folks take away from this is that the GCS is actually very valuable in providing prognosis down the road for mortality and outcome in TBI patients. In general, the lower the GCS, the worse the outcome. Motor score is probably the most valuable element, and the post-stabilization or the post-resuscitation GCS is probably the best GCS score to use. So that may vary as to when that occurs, but it's usually going to be at some point after admission or around that time at least. Duration of coma, post-traumatic amnesia can both be considered as well. So that may help you not just with whether the patient is going to survive. You've answered that question by now in a number of these cases, at least, especially with the amnesia. But it may give you a better indicator of how well they're going to do in terms of functional recovery. The age, other than GCS, is the next most important and best evidenced factor that will predict outcome. So older patients with severe TBI, worse outcomes, especially if they're older, 65. And then the lesion pattern on CT or MRI. The more lesions, the higher the likelihood for a worse outcome. And then on MRI, if you see deep lesions, particularly involving the brainstem, and if it's bilateral, that's associated with worse injuries. Try to use validated and evidence-based tools as best you can, but remember that also has limitations, and it's not the be-all, end-all for prognosis. TBI is very heterogeneous, and individual prognosis can be very challenging, because even when you have a tool that tells you what a group of people will do, that individual patient may do something completely different and surprise you, and everyone for that matter, or they may take a turn for the worse unexpectedly. So keep that in mind, that this is something that is continuing to develop and is considered quite difficult by most people, and hopefully with time we'll get better at being able to provide information regarding prognosis with the help of biomarkers and advanced imaging. With that, I'll close the talk and allow folks to ask questions if they have any. It was really an honor and pleasure to be able to talk to everybody today. So thank you very much for having me, and I hope you enjoy the rest of the program. Thank you, and we'll take questions if people have them.
Over the past year, I've seen firsthand the impact that delaying care can have on the members of our communities across northeastern Oklahoma and southeastern Kansas. So as your neighbor who works at Ascension St. John, I'm going to keep asking, how are you feeling today? Your care shouldn't and frankly can't wait. Care for your heart, cancer screenings, mental health care, and routine physicals, it's all important. Getting care sooner can mean catching things before they get worse. At Ascension St. John, our staff chose to be among the first in the nation to receive the COVID-19 vaccination. And our ERs, our hospitals, and other sites of care are maintaining strict precautions for your safety. So keep checking on family and friends. Studies have shown that 63% of people say they would be encouraged by friends and family, as well as their doctor, to get care sooner. Remind them to keep routine appointments and checkups and screenings, and to schedule an appointment to reconnect with their doctor now. Get the care you need at getstjohncare.com.
Our next speaker is Dr. Errol Gordon. Dr. Gordon completed his medical degree in 2001 from SUNY Downstate Medical School. He completed his neurology residency in 2006 from Froedtert Memorial Hospital, Medical College of Wisconsin. He completed his neurocritical care fellowship in 2008 from the Columbia University Medical Center. At Mount Sinai Hospital, he was the former director of neurocritical care. There, he helped develop the Neurocritical Care Fellowship Program. He currently serves as the clinical associate professor at the University of Oklahoma. Dr. Gordon serves in multiple capacities for the Ascension St. John Medical Center Neuroscience Department. He is currently the medical director of the Ascension St. John Neurocritical Care Program, the vice president of the Ascension St. John Heyman Stroke Center, and is the current chairman of the Ascension St. John Medical Center Department of Neuroscience. Today, he will be educating us on non-infectious encephalitides. Thank you, Dr. Gordon, for providing this lecture today.
Hello, everyone. My name is Errol Gordon. I'm going to talk about non-infectious encephalitis. I have no relevant disclosures. First, I want to mention this particular diagnosis, Hashimoto's encephalopathy. Now, many of you may be familiar with Hashimoto's thyroiditis. It's a condition, autoimmune condition that attacks the thyroid gland. Hashimoto's encephalopathy is something different. And for me, as I went through the process of becoming a neurologist, this was a very fascinating diagnosis. It was originally reported on in 1966. Basically, they had a 45-year-old man who presented with seizures, confusions, hallucination, agitation, and tremors. Right. The interesting thing was that the hypothyroidism from his apparent pathology with his thyroid gland was fixed. There was no problem with that, but he still had these neurological changes, and these neurological changes were covered with corticosteroids. Now, as it evolves, Hashimoto's encephalopathy is this interesting condition that people think are related, or it is believed that it's related to an autoimmune process. It can be chronic or acute. People could have delirium or rapidly progressive dementia. There's a lot of psychiatric manifestation. Sometimes people could be depressed. Sometimes people could have diagnosis. There may be also some short-term memory difficulties. And you have to sort of have a high index of suspicion in order to diagnose it. And it's important to diagnose it because, treating with steroids not only help with the diagnosis, but it treats the condition. And the one interesting thing is that these are patients with these neurological symptoms, and they have elevations on antithyroid antibodies like antithyroid peroxidase or antithyroglobulin antibodies. It is thought, though, that these antibodies aren't sort of the causative agents that cause the disease. They're just a marker of another process that's going on. In my career, I've seen a few cases of this, and it's remarkable sometimes how people improve with steroids. And these types of cases fascinate me, and this is one of the reasons why I wanted to do this particular talk. So taking a little bit of a step back, I want to talk about some definitions. I know there's various people or healthcare providers that are in this or watching this. And I wanted to sort of make sure that we're on the same understanding with some of the terms that I use. So meningitis. So the meninges are covering of the brain, right? And when you think of meningitis, it means some sort of inflammation of the meninges, or inflammation of the covering. And that inflammation can be either caused by an infectious agent, we call that septic, or a non-infectious agent, or aseptic. When we talk about encephalitis, we mean inflammation of the brain parenchyma itself, right? Obviously, there's some overlap. And when you have that, that could also be either infectious or non-infectious, right? And when you have an infection or non-infection inflammation, you typically have a history of fevers, you could have seizures, focal neurological signs. You could have this thing called CSF pleocytosis, meaning that the white cells, blood cells that help fight off infection or as a marker of inflammation, those could be in elevated numbers in the CSF. And you also often have abnormal brain imaging as well. So, infectious causes of encephalitis. This is like extensive list, but it's not exhaustive. Most common cause would be herpes simplex virus. This is a lot of people think about this, mostly because we have clear and defined treatment for this. People who have HSV encephalitis, they get treated with acyclovir, and oftentimes they may be treated with status as well. Other kind of important viruses that may cause encephalitis: enterovirus, West Nile virus. Historically, polio was a big issue, but helped with the vaccine. And then there's bacterial causes of infectious encephalitis, right? In kind of the adult population, strep pneumo is sort of a big concern. Also, Legionnaire is also a big concern. Sometimes we could have Lyme as well. And other agents, depending on where you live and your exposures, you could get rickettsial, parasitic, or fungal causes of encephalitis. Non-infectious encephalitis obviously have the same sort of clinical presentation: fever, seizures, focal neurological signs, CSF pleocytosis, abnormal brain injury, but you don't find an infective agent. And typically these are related to an autoimmune disorder. And most of the times, in some way, there's an antibody associated with this disorder. So I'm going to talk a lot about different antibody-associated disorders of the nervous system. Before that, though, I want to speak a little bit to some of the epidemiology of an autoimmune encephalitis versus an infectious encephalitis. An autoimmune encephalitis, the incidence is a little less common than an infectious encephalitis, 0.8 per 100,000 person years versus 1 per 100,000 person years. The age of onset is typically about the same, the average age of onset. Overall, more females are affected by infectious encephalitis than autoimmune encephalitis in terms of the percentages. There's a disappropriate effect of autoimmune encephalitis in the African American communities. An autoimmune encephalitis is more likely to have a normal MRI. And you can see more of an inflammatory CSF in an infectious encephalitis. Autoimmune encephalitis is more often associated with a malignancy, but death is more often associated with an infectious encephalitis. So things that can mimic and kind of an inflammatory encephalitis include vasculitis, lupus, disease called Behçet's disease, neuropsychosis, and then you could have the metabolic derangements like hypoglycemia, hypernatremic hepatic encephalopathy, and various toxins or drugs can do the same thing. Specific primary brain tumors or METs, depending on their location in the brain, could cause a presentation similar, and things like status epilepticus or continuous seizures that can mimic an encephalitis, but it also could be the result of an inflammatory or process in the brain itself. Cerebral ischemia and psychiatric disorders also can mimic this. So kind of created this Venn diagram to sort of break down a little bit of how these antibodies can or how to characterize how these antibodies or where these antibodies attack, because they sort of categorize these possible inflammatory or impossible autoimmune encephalitis. So some antibodies attack the synaptic receptors, right? Remember, we have neurons that have a synapse where it's the way that neurons communicate with each other. And on the receiving neuron, that connection is called a synapse. And there's certain important proteins that are integral in the communication process, and if you have antibodies attacking those proteins, that could be a problem. Then you have antibodies that actually attack antigens or inside the cells itself, right? There are disorders where the target antigens are intracellular, and then there are disorders where the antibodies are related to surface proteins or ion channels on the neuron itself, but not necessarily at the synapse. So I made a little cartoon to sort of explain. So antibodies to the intracellular antigens or neuropil, those would be antibodies to what is sort of colored in as red on the slide, and antibodies to synaptic receptors would be antibodies to proteins related in the communication process at the synapse that's highlighted with that blue box. And then antibodies to surface cell proteins or like ion channels would be sort of represented by where that green mark is on this slide. So antibodies to intracellular antigens, these are more likely to be those classic paraneoplastic disorders that were discovered associated with certain cancers, right? Basically, these antibodies cross-react with tumor cells and cross-react with nuclear or cytoplasmic antigens in the nervous system. Most of the pathology in these types of cells are mediated by T cells. So here's a list of those classic onconeural antibodies: anti-Hu, the CRIMP5, anti-Re, anti-Ro, anti-Ma, and you could see that they're associated with various different cancers, small cell lung cancers, thyomas. And these antibodies could produce similar types of abnormalities in the brain: encephalomyelitis, limbic encephalopathy, cerebellar degeneration. They could also cause problems in the peripheral nervous system as well. So the classic paraneoplastic disorders may cause an encephalomyelitis or inflammation of the brain and the spinal cord. Limbic encephalitis, subacute cerebellar degeneration, opsoclonus myoclonus, sensory neuronopathy, chronic gastrointestinal pseudoobstruction, a Lambert-Eaton type of myasthenic syndrome, or dermatomyositis. Taking another step back, I just want to define a few of these terms so that you understand what I am referring to. So an limbic encephalitis typically is a subacute presentation where there's particular involvement in a person's memory deficits. There's confusion, there's altered mental status and some sort of psychiatric disorder, and there's often seizures. And when you MRI these people, you will see signal changes in the temporal lobe, the medial aspect of the temporal lobe. That's what would characterize a limbic encephalitis. Cerebellar degeneration. So the cerebellum is sort of like this subcomputer part of our brain that's located in the back part of our brain that helps with our coordination. it makes our movements move. And this cerebellar, there are many different reasons that could cause cerebellar degeneration. It may be genetic or acquired, and it may be from toxins. Alcohol could cause cerebellar degeneration. But cerebellar degeneration implies specific degeneration in the cerebellum, kind of asymmetric to the rest of the brain. However, it may, in the syndrome of cerebellar degeneration, it may involve associated structures. So the cerebellar degeneration affects coordination in the arms, legs, and trunk. It could cause disturbances in speech, disturbance in gait, and also nystagmus, which are abnormal eye movements. Opsoclonus myoclonus. This is sort of a unique thing that if you see it, you won't forget. It's irregular, rapid movements of the eyes in multiple different directions, right? The eyes sort of bounce back and forth in kind of a erratic way. And people may also have associated myoclonus where they have sort of uncontrollable, we call it maybe ballistic movements or jerks in the extremities. And people often have abnormal gait in that opsoclonus myoclonus syndrome. There's a specific type of seizure called, a phenotypically type of seizure called faciobrachydystonic seizures. And these are sort of brief kind of seizures involving the face or arm, typically on one side of the body or another, ipsilateral side. And they are brief, they last 1 or 2 seconds, and they may occur 100 times a day. And it usually is seen in the specific a condition called LGI-1 encephalitis, right? And then I want to explain what a neuronopathy is, right? A neuropathy, everyone kind of knows about a neuropathy. Broadly, it's a disorder in the nerves themselves. When we say neuropathy, we often mean that there's problems with the neurons, the axons on the neurons, either problems with the axons themselves or problems with the myelation of the axons. A neuronopathy, I think, implies something more specific. There's a problem with the nerve cell, the cell body itself. Oftentimes it means that something is killing the nerves themselves and it causes the whole nerve to die. So going back to sort of onconeuro antibodies, initially they found those antibodies that attack the intracellular antigens or the antigens that were inside sort of a nerve cell. And then, they found antibodies that attacked the surface proteins or surface synapses. One of the most common, one of the kind of new ones or newish ones, they're not that new anymore, but the NMDA receptor, antibodies to that, antibodies to the GABA receptors, antibodies to the Casper receptors, antibodies to the AMPA receptors, and voltage-gated calcium channel receptors. And we'll talk about a little bit of the clinical presentation to people related to encephalitis in regards to this. It must be said that it's more likely, so for the antibodies that attack the intracellular antigens, those are typically mediated by T cell autoimmune response, while the antibodies themselves in these particular cases are more likely to be more involved in the pathogenesis of the illness associated with them. So a couple of years ago, we were involved with the care of a patient, a 31-year-old female. She had a history of diabetes, also had end-stage renal disease from just bad diabetes. And she presented to our hospital after being found unresponsive and was thought to be having seizures at that time. She was generally stiff, and every time you touched her, she would have more stiffness. Interestingly enough, she went to another hospital a week ago where she was newly diagnosed with seizures. Now, this young lady was in our hospital for a long time, 3 months, right? And we did, the extensive workup on her, including MRI, lumbar punctures, a significant amount of blood work. And in her lumbar punctures, on her lumbar punctures, she did have what we call a CSF pleocytosis. She never grew back any sort of infectious agent. And in fact, we did multiple CSFs on her. And we did on our second CSF evaluation, she did come back positive for NMDA receptor antibody. And given kind of her presentation, her abnormal movement disorders, the fact that she was in status, we felt that she had an NMDA receptor antibody encephalitis, and we treated her with plasma exchange and rituximab. She made a pretty significant recovery. She was in the ICU for several weeks, had epistotonic posturing, was essentially unresponsive for several weeks. And then after our aggressive treatment with the immunomodulation, immunosuppressive therapy, she slowly recovered. Even on follow-up, though, as an outpatient, she still needed pretty significant assistance with walking, and she had significant memory deficits. In the hospital, she had extreme emotional lability. That improved, but it still remained even on follow-up. Now, this NMDA receptor antibody, right? The NMDA receptor is a ligand-gated ion channel. It causes excitatory neurotransmitter. Basically, it's a glutamate receptor, and the receptor itself is created between a combination of 4 different subproteins, right? And you have NR subprotein units. They could be NR1, NR2, NR3, and the antibody that causes this classic syndrome is typically to the NR1 kind of subunit. That NMDA antibody, NMDA receptor is distributed throughout the whole nervous system, and typically it binds glycine and glutamate that activates it, and it causes an influx of cations, specifically calcium. So the NMDA receptor encephalitis, it's a characteristic neuropsychiatric syndrome. Typically, you see it in women and young children, but it can happen in males as well. There's a viral-like prodrome, and people could have memory loss, seizures, decreased consciousness, and dyskinesias, where there's this all abnormal movements in the mouth, face, and trunks, as well as limbs. So younger patients who suffer from this, they typically present with more of the neurological problems, like the seizures. The older patients typically present with more memory deficits. 45% of females have either unilateral, bilateral teratoma, and oftentimes, in order to help improvement, those teratomas need to be removed. So that's something that we always look for in young women, and there's a discussion about removing those teratomas, typically located in the ovaries. And oftentimes these patients spend a very long time in the ICU and have dysautonomia and respiratory instability that requires them to be on a ventilator. They also have seizures as well. So CSF may show pleocytosis, meaning that there may be more white cells in the CSF than typical, and there may be lymphatic or lymphocytic predominance, meaning that those white cells are usually lymphocytes. You're less likely to have increased proteins or oligoclonoblasts with this NMDA receptor encephalitis. And basically, it's essential that you get CSF in this particular condition because the CSF may be positive for the receptor as well, more so than the CSF being positive in the serum, more so than the antibody being present in the serum. Another receptor antibody that can cause an encephalitis is an antibody to the AMPA receptor, right? And this condition could give you symptoms of a limbic encephalitis. It could cause subacute confusion, disorientation, memory loss, psychiatric symptoms, typically affecting middle-aged women. There's a 70% association with cancer, either lung or breast, are typically common. Interestingly enough, this condition also is associated with elevated thyroid peroxidase antibodies, and their ANA may also be positive. Again, the CSF is predominantly lymphocytic, like in an MDA receptor antibody, and because we see limbic encephalopathy, oftentimes you see the abnormal signal in the medial aspects of the temporal lobes. GABA receptor antibodies could cause an encephalitis, and there's two types of GABA receptors, an A or B, and the antibodies to A or B could cause a slightly different, or a different syndrome. So GABA A receptor antibody encephalitis, rapidly progressive. They often have refractory seizures, kind of continuous seizures that can't stop. We call that status epilepticus. And there's a specific type of continuous focal seizures called epilepsies partialis continua, where it's continuous focal seizures that are pretty difficult to treat. All the seizures may be preceded by behavioral changes. And again, in the CSF, you may see a lymphocytic pleocytosis and increased protein concentration. You see those changes on MRI consistent with a limbic encephalitis. Rarely do you see underlying tumor with a GABA A receptor, but it's important to diagnose because this condition can be responsive to immunotherapy. GABA B receptor encephalitis, seen both in men and women. In this condition, seizures are more prominent initially as opposed to the behavioral changes. This condition can be more often associated with tumors, including lung cancer or neuroendocrine tumors of the lung. More specifically, the patients who have the tumors are typically older, in their 60s, than the people without the tumors, who are typically in their 30s or late 30s. The encephalitis usually precedes the diagnosis of the tumor itself. This condition is frequently associated with other antibodies, including thyroid peroxidase, ANA, and GAD, or GAD65, antibodies to GAD65. So voltage-gated potassium channels, right? So these are proteins, or these proteins are in both the central nervous system and the peripheral nervous system, and they mediate sort of the repolarization or the kind of recovery of a neuron after it has an action potential. And it used to be that we thought that people had antibodies to these receptors itself. Instead, when you look at these proteins, it's actually a big complex, and there's certain subproteins that we may develop antibodies to, and two in particular that have two different sort of syndromes. The first one is the leucine-rich glioma inactivated protein, the LGI1, and then there is the Casper2 protein, both of which antibodies to this can cause an encephalitic syndrome. That's important to talk about. So the LGI1, there's a high concentration of this protein in the voltage-gated potassium channels in the hippocampus and neocortex. We know that mutation in this kind of protein could cause like a temporal lobe epilepsy syndrome. Essentially, helps in sort of connecting things in the synapse, and it's involved with that kind of repolarization of AMPA receptors as well. The encephalitis related to this, antibodies related to this protein, you see in older individuals. Oftentimes this is associated with hyponatremia. They may have REM sleep behavior disorder. They may also have myoclonus, and they may have this tonic, dystonic facial syndrome. This is the frontal brachial dystonic seizures that I was mentioning before. And these abnormal movements may precede the encephalopathy associated with this. So the CSF in this particular situation may be normal, but if there's abnormal CSF production of these antibodies, you may get oligoclonal bands. Less than 10% of these folks have a neoplasm associated with them, and if they do, it's usually a thymoma. The Caspr-2 it's an adhesion molecule that's both in the central nervous system and the peripheral nervous system, and it helps aggregate potassium channels. Mutations in this protein could cause schizophrenia, psychosis, autism, and refractory seizures, as well as mental delay. Anti-Caspr-2 antibodies associated encephalitis can lead to this thing called Morvan syndrome, where you have hyperexcitability in the peripheral nerves. It can have this thing called myotonia, where you press a nerve and it causes the muscle to kind of have a sustained contraction, and there's an abnormal sound when you do an EMG. And the antibodies may be actual negative when you test it. A limbic encephalitis is actually seen in a minority of the patients, and there may be an association with other kind of antibody-mediated disorders like myasthenia gravis. But fortunately, the anti-Caspr antibody encephalitis is also improved with response to immunotherapy. Another protein, the DPPX antibody, can cause, an encephalopathy, rapid progressive encephalopathy, CNS hyperexcitability. People could have agitation, hallucination, myoclonus, and seizures. They also may have GI symptoms like diarrhea and weight loss. Ataxia and nystagmus can be seen, and they may have an exaggerated startle response. This antibody is not associated with cancer. GAD antibody is an interesting antibody in that it's not a surface antigen. It's actually an intercellular enzyme, and it's seen in both neurons and pancreatic cells. So people with anti-GAD, that should be GAD65, they could have diabetes as well. So this GAD catalyzes the synthesis of GABA. GABA is sort of an inhibitory neurotransmitter, so problems with GAD can lead to overexcitation. The classic sort of thing that we worry about is stiff person syndrome that you can see, but you could also have a limbic encephalitis and refractory epilepsy associated with anti-GAD antibody. And then we have glycine receptors that if you develop antibodies to, you can get kind of a brainstem or spinal cord hyperexcitability disorder, which is, I think, seen in children. There are other mGlut-R1, mGlut-R2 as well. These are paraneoplastic antibodies that you can see, and they're often associated with Hodgkin's lymphoma. And then dopamine 2 receptor antibodies reported in children could cause a basal ganglia encephalitis, which means it will lead to sort of a chorea or Tourette syndrome and not associated with cancer. So went through a lot of different conditions, and there's a lot of overlap. I think the biggest thing in terms of trying to diagnose these things is having an index of suspicion for someone who presents with these abnormalities. There are commercially available screening tests that would screen for these different antibodies, both in the CSF and serum. And if you see someone who presents with these bizarre symptoms, it's important to test for them. More so than that, right? Oftentimes, even though they're commercially available tests for them, it may take some time to get those results back. So if these people present with the classic symptoms, it may behoove you to start treating them with the immunosuppressive or immunomodulating therapy before you get those results back, barring you're absolutely convinced that there's no infectious cause to those presentations. So treatment. Typically, people would start off with high-dose corticosteroids. We often use IVIG or intravenous immunoglobulin as well. Plasma exchange is also can be effective as well, but oftentimes people may need a rituximab infusion or cyclophosphamide. And that's the direct kind of immunosuppressive or immunomodulating therapy that you would use in some of these cases. Oftentimes people present with seizures, so seizure management is also important. People may need to be aggressively treated for status. And a lot of these antibodies are associated with malignancies or tumors. And so tumor screening is also very important. And in the case of the NMDA receptor antibody encephalitis, removing a possible teratoma could be important in terms of the recovery of the patient. And overall supportive care. Now, just a little bit more focus on the seizures, right? Seizures can be seen in most patients with surface antibody autoimmune antigens, right? So that's the GABA, LGI1, Casper, AMPAR, NMDA receptor. Taken to heart, right? A lot of these people don't develop chronic epilepsy. With anti-NMDA receptor encephalitis, on the EEG, you could see this thing called extreme delta brushing, which is a normal pattern that it's almost pathognomonic for this NMDA receptor encephalitis. But seizures can also present with the encephalitis associated with the intracellular antigens as well. Those aren't as well treated with immunotherapy as the surface antigen antibodies. And so, in fact, those have a more poor prognosis overall. So, there are other autoimmune epileptic disorders that are associated with antibodies. Rasmussen's encephalitis, which you could see refractory motor seizures in children, Fire syndrome that begins in a child after having a febrile syndrome and could be pretty devastating. But there's another kind of concept called NORS, new onset refractory status epilepticus. It's a person who presents with status that's refractory to the kind of first line treatment, who's never had seizures before. It's important to think in these patients about one of these autoimmune encephalitis sort of diagnoses, because 40% of these cases may have an underlying autoimmune etiology. And so having that high index of suspicion would allow you to test for these antibodies, and oftentimes the status may be treated or helped be treated not only with the typical management for status, but immune modulation. Okay. And that's it. Thank you all.
Thank you, Dr. Gordon. We've had a couple of questions come in during your presentation that we would like to take a few minutes of your time to answer. Our first question is, in Oklahoma, what is the most common viral etiology of encephalitis that you and your team see?
Far and away, it's HSV encephalitis, right? People often present with status related to this HSV encephalitis. Interestingly enough, I didn't mention this in the talk, but oftentimes people, after they are affected with HSV encephalitis, they may develop antibodies to the NMD receptor antibody, and there might be persistent psychiatric illness related to that. So that's something to look out for as well.
Okay, thank you. We have one more question that came in. Are people often misdiagnosed for psychiatric illness who actually have encephalitis?
Yes, and sometimes it's very difficult to differentiate initially, but I think it's important to know if people don't have a history of psychiatric conditions, if they had a fever or kind of viral type prodrome, if there's a prominent memory process or memory abnormality, and if the confusion, the psychiatric illness is over a couple weeks. Those are people that maybe need to be evaluated more fully to make sure that there's not something that is reversible with immunotherapy.
Okay, all right. Well, thank you again, Dr. Gordon, for your presentation and for your time. And up next will be our next speaker.
I want to thank all of you for streaming with us today. Before we sign off, I want to give a big thank you to the following persons: Sonia Boswell, our PA and lead organizer; Dr. Earl Gordon, Director of Neurocritical Care; Candace Evans and her team from marketing; Whitney Dockery from Community Outreach; and the American Heart and Stroke Association. These are interesting times that we're all living through, but we must remember to take care of ourselves and each other. Thank you and good night.